The meeting's called to order. I want to first thank everyone for being here, particularly our panelists. The subcommittee today is holding the first in a series of hearings entitled Making Healthcare Work for American Families. These hearings will help us better understand issues important to the healthcare reform debate, such as quality, cost, coverage, and prevention. And today we're focusing on how to design a high-performing healthcare system, which implies that our current system is underperforming. Indeed, as it is presently structured, the U.S. healthcare system is incapable of consistently providing access to quality and affordable care to every American. And a large part of this failure can be attributed to our nation's growing uninsured population. According to a new report on the uninsured by the Institute of Medicine, who we'll hear from later today, 47.5 million Americans, or an estimated 17.2% of the non-elderly population, went without health insurance in 2007. As we move forward with health care reform, we must understand that our failure to insure 47 million Americans has significant consequences for the health system as a whole. Our nation's growing uninsured crisis impacts us all, regardless of our own insurance status. If we're to design a high-performing healthcare system, the foundation of such a system has to ensure access to quality and affordable coverage for every American. But the problems we face with our healthcare system go beyond coverage issues. Our healthcare system is woefully disorganized, so much so it's hard to characterize it as a system at all. There's virtually no coordination of care among providers. Patients are often handed off from one provider to another. In the process, information is lost, inappropriate treatments or tests are ordered, and medical errors occur. This is particularly a problem when it comes to patients who suffer from chronic conditions and are under the care of multiple providers at any given time. Researchers have suggested that part of the problem stems from the fragmented way in which we finance the delivery of health care services. We pay providers based on volume, regardless of the quality of the care or service provided, and regardless of the outcomes. Furthermore, there's little incentive for providers to follow up with a patient after they've provided treatment, or to coordinate care among multiple providers or between different healthcare settings. What has this disorganization created? Well, the United States spends more on healthcare per person than any other industrialized nation, and yet we do not enjoy better health outcomes by almost any measure. And within the United States, there are vast disparities in how healthcare is delivered among the different communities. Clearly, we're not getting the most value out of our healthcare dollars. The erratic and chaotic manner in which our healthcare system is organized can't continue. We need to find a way to reorganize the healthcare delivery system in a way that improves quality and efficiency, thereby driving down costs. And there are a number of options on the table. For example, the President's budget contains specific proposals that would change the way Medicare pays for and delivers health care, including 1, reducing readmission rates at hospitals, 2, providing performance-based payments for physicians that coordinate care for Medicare beneficiaries, and 3, promoting coordinated care between acute and post-acute care settings through bundled payments. Now, I know we have MedPAC here today. I'm happy that they're here because they've done work in many of these areas, as well as other areas like the medical home model. As Chairman Hackberth notes in his testimony, Medicare can be a leader in reforming the healthcare delivery system, but changes to the way Medicare delivers and pays for healthcare will only take us so far. We need fundamental change through the entire healthcare system in order to achieve our goals. Now, one of the best examples of change, I think, was in the economic recovery bill. As you know, there's a pot of money for healthcare information technology, and that's certainly an example of the systematic change we need. As more physicians are able to adopt and use HIT, we can facilitate greater communications among providers and thereby increase the coordination of care. By passing the Economic Recovery Act, we started the process of modernizing our healthcare system by investing $19 billion in HIT. But not everything has to be as complicated as moving our healthcare system into the electronic era. There are simple changes that will produce dramatic effects. For instance, I believe that by focusing more on primary care, coordinated care models, and prevention, we can achieve greater savings and efficiency within our healthcare system. And again, there are prevention and wellness measures and pots of money in the Economic Recovery Act as well. If we're successful in redesigning our healthcare system so that it performs better, there will be great rewards. Aside from the potential to improve health outcomes, a more efficient healthcare system that pays for quality services will help drive down costs for American families, businesses, and the federal government, all of which are struggling with the escalating cost of healthcare. Indeed, healthcare reform is fiscal reform. Those of us who've been paying attention to the President over the last month or so, he constantly talks about healthcare reform being fiscal reform and the need to bring down costs if we're going to effectuate an economic recovery and expand coverage for all Americans. We can't restore the financial health of the nation and American families without tackling our broken healthcare system first. So let's get started. I just wanted to say, many of us on this committee attended the President's Healthcare Summit last Thursday. I was tremendously impressed with the fact that almost everyone said that we needed health care reform now. They did not want to wait. And almost everyone said that the cost and bringing down costs was an important part of any change that we're going to effectuate. I used to be very proud of the fact that I could go around and saying I was involved in health care policy and that we had the best health care system in the world. I don't believe that anymore. And I think the time to act is now. And so we're going to begin today. I now recognize our ranking member, Mr. Deal, for an opening statement.
Thank you, Mr. Chairman. I want to thank you for holding the hearing today. I want to thank both panels of witnesses who are going to testify. In particular, I would like to go ahead and welcome, even in advance of his official introduction, Dr. Todd Williamson, who is a neurologist from Georgia and is president of the Georgia Medical Association. He'll be on panel 2, and thank you for allowing him to testify. You know, when you talk about health care, you're talking about how to wrestle a porcupine. And the problem I think we have encountered is that we have known different ways to deal with this issue in small pieces over a long number of years, and we have failed to come to grips with dealing with those pieces. And now we are trying to deal with the system as a whole and talk about how bad the system is, even though we have not taken advantage of the opportunities to make it better incrementally. I'm always concerned about major reforms, especially of a segment of our economy and of societal service as large as health care. But we are now apparently on the brink, for whatever reason, dereliction of duty in the past or whatever, of having to deal with major reform. Now let me mention a couple of things that I hope in the context of this hearing, perhaps even more specifically in future hearings, I think are important to deal with. First of all, I have had a passion for the issue of price transparency. In the healthcare arena, it's one of the few areas that you just cannot know in advance of a service being rendered what the charge is going to be. And the reason is, and it indicates part of the problem we're wrestling with, is the reason you don't know is because the question is always followed with a question. When you ask how much is it going to cost, the question becomes, well, who's going to pay? And who pays depends on how much the cost really is. And that's something that you do not find in most other areas of service in our nation. So price transparency is an issue, and I'm pleased that the chairman and the chairman of the subcommittee have both indicated a willingness to explore that issue in the future. But let me talk about a couple of other things. I think you're going to find that throughout all of this, the issue of medical malpractice reform has got to be one of those issues that we just simply cannot ignore. Now, it manifests itself not only in private physician and hospitals practices, but also the one that is probably the most acute that we tried to deal with several years ago, and that is the emergency rooms. With EMTALA required to treat everyone, with no ability to divert without running the risk of being held accountable on a liability basis, you're just simply going to continue to see, as in my local emergency room, the primary reason for presentation is ear infections. And you probably could duplicate that all across the country. Non-emergencies being presented in the most costly environment, that is an emergency room. But until we deal with the ability either to alter EMTALA, which I have no confidence that that will be done, or to provide some protections, as we attempted to do several years ago, for diversions to non-emergency settings in an environment close to the emergency room so as to take that pressure off and the financial as otherwise the pressure off, I think we still have a problem there. Now, there are other issues, and I'm just going to deal with them in very broad, general things. First of all, I think we have to remember that as we're dealing with an expansion of government power, we never can forget about the fact that the only thing that keeps our country working in almost every facet of life is the issue of personal responsibility. When we have government assuming all of the responsibility, then it is very difficult to get people to do what they need to do for themselves, not only financially contributing to the cost of their health care, but to doing the things that they need to do that the chairman has alluded to, such as prevention, such as wellness programs, et cetera. A few other things that I'd like to mention. I think that as we deal with the broader context of how to reform the delivery system, hopefully we will not forget the private sector. The private sector has been the primary mechanism for providing health insurance through the employer-based system. Obviously, it has some problems. I would like to see us be able to take advantage of the one that has the most personal responsibility, and that is a medical savings account where a person has the right to decide how they want to spend their money, and they're directly involved. But they can't be the ones that are paying the highest price. If that's the case, then you can't make that kind of system work. Thank you, Mr. Chairman. This is certainly the beginning, I hope, of a wide-ranging look at the issue of health care reform, and thank you for hosting this hearing today. I yield back.
Thank you, Mr. Deal. I'm going to recognize our chairman, Mr. Waxman, but let me just digress a minute here, if you'll bear with me. There are a lot of people on this committee who have played major roles over the years in the health care debate, and if we do actually accomplish health care reform in a significant way this year, I think that we owe a lot to them, and Mr. Waxman, Mr. Dingell, others are amongst them. And I just wanted to say, I remember 20 years ago, because this is my 20th year, I came to this room and I watched Mr. Waxman and Mr. Dingell and others talk about health care issues, and I was so impressed. That's why I wanted to be on this committee. And I know that's why a lot of the new members have started. We have a number of new members on our health subcommittee this year, and they've expressed the same thing to me, that the main reason they came to this committee was because they wanted to deal with health care reform. But if and when we accomplish this goal this year, a lot of the credit is going to go to some of these people who have labored for years on this issue and brought out a lot of the problems and solutions that are necessary for health care reform. And certainly our chairman is the leader, or one of the leaders amongst them. So I just wanted you to know that, Henry.
Thank you very much, Mr. Chairman. And when we accomplish the goal of enacting health insurance, affordable health insurance for all Americans, you will be there ranking among all the members who have played a significant role. This isn't one or two, it's all of us working together. And I thank you for holding this hearing on the health reform issue. I think we have a unique opportunity. President Obama has called on Congress to work with him to enact comprehensive health reform this year. And to underscore his commitment, the President has proposed over $630 billion in new revenues and program savings to help pay reform. This marks a sea change from the last 8 years, and as we'll hear from our witnesses today, it comes none too soon. The status quo is simply no longer an option. The health of our people, the health of our economy depends on achieving affordable, high-quality, sustainable coverage for all Americans. The President has laid out the broad outlines of his preferred way to achieve this goal, and I think his approach is sensible. It builds on and protects the employer-based coverage that's now in place for most Americans. It lets those people who have coverage that works for them keep that coverage. It strengthens the safety net of our vital public programs, Medicare, Medicaid, CHIP. It gives people a place to go to get accessible, affordable, high-quality coverage through private plans, or if they prefer, through a public alternative. The choice is theirs. And it recognizes the critical importance of prevention and wellness services and the management of chronic diseases. I'm determined to work to find the approach that will be broadly acceptable to the American people, to the providers that are critical to making it work, and to the members of Congress who in the end have to pass it. This hearing begins the work of this committee in responding to the President's request. As the testimony will make clear, the health care challenges we face are daunting, and finding workable and enactable solutions will be extremely difficult. Mr. Chairman, you as chairman of the subcommittee will build on the work that I and Mr. Dingell and others have done over the years, and you and the newer members of the committee will bring a vitality to this effort that I think will finally get us to the goal that has been so elusive. And I look forward to working with you on this in this regard.
Thank you, Mr. Chairman. Next is our ranking member of the full committee, the gentleman from Texas, Mr. Barton.
Thank you, Mr. Chairman, and I want to commend you and full committee Chairman Waxman for the bipartisanship in arranging these series of hearings. This is not like the hearing upstairs on climate change, where there is a clear ideological difference, and we have even gotten to the point of arguing over how many witnesses and which witness and this type of thing. In this subcommittee, under your leadership and Mr. Waxman's leadership, it's been a very cordial operating relationship, and I do sincerely want to commend you and Mr. Waxman for that. Health care is very important to everybody in America, and I do slightly disagree with your opening statement, Mr. Chairman, when you said that you used to think the United States had the best health care system in the world, but you don't think we do anymore. I think we still do. I think our health care system is the best in the world. I think it's the best in terms of quality. I think it's the best in terms of inclusiveness. I think it's the best in terms of its research capability. I do think there are problems with it. I think that obviously Americans that don't have health insurance are not able to take advantage of some of the wellness programs and the preventive medicine practices that are becoming more and more prevalent. But if somebody in America is sick today and needs to see a doctor or a health care practitioner, they're going to see them. Whether it's in an emergency room or a clinic or a private doctor's office, they're going to see them. And the more serious the condition, the more fortunate that person is that they're in the United States of America. My sister-in-law has just undergone 6 weeks of chemotherapy treatment at MD Anderson in Houston, Texas. She went home Sunday to recuperate. Her CAT scan and the tests that they run show that the cancer that is ravaging her body is beginning to recede because of the treatment that she is receiving and hopefully will continue to receive after her body recuperates. I'm darn glad that she lives in the United States of America, and I'm very glad that she lives close enough to MD Anderson in Houston, Texas, that she could take advantage of the treatment that's available there. People come from all over the world to that facility for that type of treatment. So what we're engaged here today, Mr. Chairman, is to begin a discussion of how we can improve our health care system. And I think we can do it. I do think our health care system is too expensive. I do think that there are lots of ways that we can improve it. I agree with you that the President's health care meeting at the White House last week was very productive. I said there, and I'll say here, I agree with President Obama's 8 principles. But the devil is in the details, and that's what these hearings are going to accomplish. I think there is a difference between Republicans and Democrats. In general, I think the Democrats, the majority party right now, want more government involvement in health care. I think Republicans in general would rather have the private sector and a marketplace system with openness and transparency where doctors and patients make the decisions themselves and don't have to depend on some sort of a government official or a government program. But I do think the government needs to be involved, and I think that somewhere in these hearings perhaps we can have a meeting of the minds. So, Mr. Chairman, I am involved in the health care debate in this committee in a different way than I am the climate change hearing issue. I think on health care, we can improve the system, and we can find a consensus, and we can do something hopefully this year to make health care for Americans more affordable and more accessible and even higher quality than it is. I must say on climate change that I'm hopeful that we can convince enough people that's not something that we need to do given the state of our economy. In any event, this is a very good hearing. You've got good witnesses, and I look forward to a serious discussion.
Thank you. I'm going to thank our ranking member. Next is our Chairman Emeritus, and I cannot have enough accolades about his involvement over the years in health care reform and Medicare, and again, look to him as one of the giants on this issue. Mr. Dingell.
Mr. Chairman, I thank you for those kind words, and I thank you for holding this hearing, which is a very important one, about designing a high-performance healthcare system. We have a splendid healthcare system in this country which doesn't work. It doesn't work because we have 47 million Americans who lack care, and we have a lot who have substantial deficiencies in the amount of care available to them. We have a worse situation in that the problem is fixable, but it has not been able to be addressed for years because of intense lobbying by the health insurance lobby and others. I remember we lost it the last time by 1 vote here. And we lost it in good part because of dawdling by the administration, which made a fine speech on the subject on the floor of the House in February and didn't present the bill to the House until sometime in November, by which time we had lost in this committee and in a meeting of the Business Roundtable by 1 vote. The health care system in this country is wonderful, but it doesn't work. And one of the problems about it is that we're seeing large numbers of Americans die prematurely or suffer from serious health problems because of the lack of availability of care from this extraordinarily advanced system which we are blessed with. Health care costs are far higher in the United States than in any other advanced nation. These costs have been rising significantly faster than the overall economy or personal incomes for more than 40 years, and if left unchecked, will shortly create irreparable harm to the nation's health and economic system. The two curves which are important to us in this country, the GDP and the cost of health care, or the percentage of health care, will cross about 2070. That should give us a warning. We've heard the data. Health costs are consuming a growing share of federal and state government budgets. The United States spends $2.2 trillion and more on health care each year, about $8,000 per person. This represents 16% of the total economy and is expected to reach almost 20%, more than $4 trillion by the year 2017. Health insurance premiums have doubled over the past 8 years, raising 3.7 times faster than wages in the last 8 years. And American businesses are due to losing business share in world competition because of the increasing cost of health care for their employees. For example, a General Motors car today contains about $1,600 in health care costs per car. General Motors is in fact not an automobile producer, but a health care provider that makes automobiles to pay for the cost of it. And the same is true for many other U.S. corporations. American automakers spend more now on health care than steel. They only spend $750 on steel. And Starbucks spends more on health care than they do on coffee beans. No one can dispute the fact that we spend a great deal of money on health care. America enjoys the most outstanding cadre of healthcare professionals on the planet, the most advanced technologies, the most innovative healthcare institutions, and the finest medical research, which is a model for the whole world. However, in spite of this great investment and the amazing talent of our health workforce, our health system continues to operate at low performance, and more spending has not and does not mean better quality service and care available to the American people. Studies have shown the United States underperforms relative to other countries on most dimensions of healthcare performance. It has lower life expectancy and higher infant mortality, amongst other things. But there's plenty of other things wrong if you will read the statistics. A number of other studies have shown that many surgeries are performed without being clinically appropriate. Patients typically receive about half the recommended treatment and services. About 100,000 Americans die from medical errors in hospitals every year. Half of these cases are avoidable. One quarter of medical spending goes to administrative and overhead costs, something which we must address if we're to save ourselves from a crazy system that is failing. Across the nation, healthcare costs vary substantially, however, and higher cost areas, surprisingly, do not generate better health outcomes. Our goal of providing health care securities for those struggling to keep the coverage they currently have while expanding coverage to the 47 million Americans currently without coverage is clearly necessary. However, we must all do what we can to first make our current system of health care more efficient and effective, including the care provided by public programs like Medicare and Medicaid, the cost of which without reform will become unsustainable in the near future. The current payment structure of these systems do not encourage coordinated care and encourage unnecessary treatment, which in turn leads to higher costs and significant inefficiencies. I look forward to the testimony of our witnesses today and to continuing our discussion and action as we seek to reform our health care system. Mr. Chairman, this has long been a passion of mine, as you have noted, and also of my great father, who introduced the first legislation on this in 1943. I look forward to working with you and with Chairman Waxman and the others of my colleagues on both sides of the aisle to solve this terrifying problem. Thank you, Mr. Chairman.
Thank you, Chairman Dingell. Next, we have the gentleman from Kentucky, Mr. Whitfield.
Chairman Pallone, thank you very much and for this hearing on making health care work for American families. We all hear a lot about health care reform, and we know that there are basically two reasons that we're moving down this avenue. One, health care costs continue to escalate, health insurance premiums go up, and then access for all of the American people. And I noticed that President Obama in his budget has set aside $634 billion for health care reform. And although his plan is quite sketchy, the one thing that he has talked about specifically is a federal board to set provider rates, design coverage, and ultimately control prices in the health care market. I think from a philosophical point of view, healthcare reform gets down to a debate on both sides of the aisle. When we talk about these federal health boards, most of us, I think of Canada and Great Britain. They both have federal boards. And the key issue, at least from my understanding, is that in both of those countries, while the primary health care delivery system is very good, they basically rationalize health care, and that's something that we've really never done in America, so that if you do not meet a certain criteria, then you're not going to be eligible for a particular kind of health care procedure. That's something I think we have to move very carefully with as we discuss health care reform. A second thing, it looks like to me that I philosophically believe that a federal board is not the way to go. Because when you talk about an effective health care system, I like to look at Part D of the prescription drug benefit under Medicare. Because today we know that the premium for that plan is less than what was originally anticipated. The cost of that plan is less than what was originally anticipated. And the reason for that, in my view, is that in every jurisdiction, you had private companies coming together, competing with each other, offering plans. And more important than the cost is that the senior citizens seem to be satisfied with their Part D prescription drug benefit. I know that not all of them are, but generally speaking, they're satisfied. And I think that is a model that, as we talk about health care reform, that we definitely need to explore, giving patients more of an opportunity to decide for themselves rather than a federal board making all these decisions. And I'll yield back and balance my time.
Thank you. Next for an opening statement is the gentlewoman from Colorado, the gentlewoman from Colorado, and thank you again for your work on stem cell.
Thank you very much, Mr. Chairman. It was a banner day yesterday. I was just telling Congresswoman Capps about my sister, and I think I'm going to talk about that because it's why we have to do something about health care in this country. My sister is married to a fellow who has worked for one of the local school districts for many, many years. And she's a stay-at-home mom. She homeschools her kids. And they're middle-class Americans. Their insurance premiums, working for the school district, are $1,100 per month, with co-pays and exclusions and everything else you could imagine. And about a year ago, my nephew, as teenage boys will, was skateboarding and broke his arm at the skateboard park, and his friend's parents couldn't find my sister to ask what to do. It was a compound fracture with the bone sticking out. So they took him over to the local emergency room, and then her insurance company refused to pay the bill because they said they didn't get pre-approval. And that's what kind of health care system we're living in this country, and that's why we need to have comprehensive national health care policy. And that's why, Mr. Chairman, I'm so grateful to you and also Mr. Dingell and also the President for pushing this through. We've got to do something about a system where we're spending over $2 trillion a year, but our health outcomes are abysmal. I just want to reference really quickly two studies that we've seen recently. In 2007, the Commonwealth Fund did an international health care survey where they compared the American health care payment and service delivery system to 6 other countries and found huge disparities. For example, the United States spends $6,697 per capita on health care services, which is more than double the per capita expenditures of all the other countries. Canada was the next highest, spending only $3,326 per capita. Well, you could say we have the best health outcomes in the world, which is what many people assume. However, this is simply not true if you look at the rest of the data. For example, the most recent data from the Centers for Disease Control ranks the U.S. 29th worldwide in terms of infant mortality, and it also ranks us 31st worldwide in terms of life expectancy and 24th in terms of women's health. The U.S. ranks 37th overall in the world for health outcomes, just below the Dominican Republic and Costa Rica, and just above Slovenia. So if anybody thinks that we don't need health care reform in this country, they not only need to look at these statistics, but the statistics that average American families, middle-class families, are dealing with every day. Thank you very much, Mr. Chairman.
Thank you. And next is the gentleman from Texas, Dr. Burgess.
Thank you, Mr. Chairman. I appreciate you holding this hearing as well. So much of what we discuss, I have an opening statement that I'll submit for the record. It's very thoughtful and well written. But let me just make a few comments because of what I've heard. We spend so much time talking about cost and coverage, and I do implore us to remember that health care is first, foremost, and always about taking care of people. I also urge us not to let the perfect become the enemy of the good. Now, we heard the President talk on Thursday of last week down at the White House at the forum that the only thing that was not acceptable is the status quo. Well, true, there are things we can make better and that we should strive to make better, but I promise you, having spent 6 years now in this body, I know we can make things worse, and we must be careful that we don't do that. I certainly don't want to diminish the contributions of any of the the men and women who work in the American healthcare system, because I know firsthand that they do day in and day out a tremendous job. Now, just a word about 1993 and 1994. I was not here then. It is often talked about in healthcare policy circles as the failure to improve healthcare in this country, but I would just simply submit the world has not been static. The healthcare world in the United States has not been static since 1993, 1994. Indeed, some of the things that came out of the failure of the Clinton healthcare plan, certainly medical savings accounts were one of the things that came out about that. The state children's health insurance program was one of the things that came out after the failure of the Clinton's plan, and I would argue that these are good things. On the issue of medical savings accounts, the fast forward to the present time with what we've seen in the improvements with health savings accounts, just a personal story that I'll share with you. In 1994, I had an adult child who finished college and moved back home and chose not to go to work. I don't recommend that if anyone's considering that for themselves. Don't try this at home. But I could not get an insurance policy for any price. I was willing to write a large check for that insurance policy. Fast forward to today, and last Friday I went on the internet and looked under ehealthinsurance.com, and for what would be a comparable situation, a 25-year-old female, and I used the Washington, D.C. area code, actually you could purchase an HMO plan through Kaiser here in D.C., $98 a month, no $20 copay, but not a high deductible plan. In fact, there was no deductible. So there are options out there for people who don't find themselves without insurance that were not available in 1993 and 1994. So please let us not fool ourselves that the world has been static since then. Certainly, examples of how we can make things worse. Look what we did with the health information technology and the stimulus bill, and I tried to offer an amendment so that we could use these funds in June of this year, but instead it's June of 2011, and we have doctors' practices all over the country that have lifted the pen, literally lifted the pen off the check, and are going to wait an additional 2 years before they write that out. We must look at the things that are actually working today. Affordability does remain key in the equation, but let's look at the things that work and not just focus on trying to expand the things that don't. Certainly, employer-sponsored insurance, the price is increasing over 7% a year. Medicare and Medicaid, we know, increase at 7.4% a year. Consumer-directed health plans increase at 2.2% a year. Shouldn't we take a lesson from Safeway and Walmart and what they've been able to do with forward-leaning plans that they have implemented before we just simply provide a program essentially equivalent to Medicaid for all? And if we're going to do Medicaid for all, shouldn't we also do that for members of Congress? I introduced an amendment like that on the S-CHIP bill, and I got no votes in the Rules Committee for that. Dr. Zerhouni has come to this committee and talked about a time when medical care is going to become a great deal more personalized. He says because of the human genome, we're going to be a great deal more predictive. We can, as a consequence, be a great deal more preventive, and it is going to require us to be more participatory. That's the direction in which we need to be moving, not in a direction that's going to harm that forward progress that we've already made. And, Mr. Chairman, you've been generous with your time, and I'll yield back.
Thank you. Next for an opening statement is Ms. Capps. Let me mention that once again, she is the vice chair of this subcommittee, and deservedly so, since she's done so much work on healthcare, particularly on healthcare professionals.
Thank you, Mr. Chairman. I'm so pleased we are beginning our hearings in this Congress on health reform. It is clearly, in my opinion, the #1 issue this subcommittee needs to address. And as the President has articulated in his Health Summit and so many other places, our efforts at overhauling our nation's broken health system are really integral to our work in improving the economy. I'm eager to hear from today's witnesses about how we arrived at this point in the first place. Why does the United States, and we've heard a lot of documentation in the opening statement so far, with all of our innovation and our spending, why do we measure up so poorly against other industrialized nations? Why do we have such high infant and maternal mortality rates? Why do we have a lower life expectancy? Why do we pay so much more but receive so much less? Our next steps, of course, are how to address these factors that plague our healthcare system. I'm counting on a certain absolute, that in any solution we offer or pursue, we should bring and will bring prevention and wellness back into the fold as a core ideal. During the Bush administration particularly, there was very little attention given to the importance of prevention in health care. And because of that, our nation's public health infrastructure has suffered. We need a system that incentivizes primary and preventive care not one that simply responds to chronic diseases and emergencies, often in the emergency room. We need a system that invests in our health workforce so that enough nurses, physicians, and a myriad of other professionals are available to treat people and to work with them. Not one that divests from medical and nursing education or cuts reimbursements. I'm glad to see this issue is on the agenda for future hearings. In closing, I just want to underscore the urgency with which we must address the current crisis. It is very real today in the communities we represent, in communities across this nation, in rural areas, and in the inner cities. And I very much look forward to hearing what our witnesses are saying today, and I yield back.
Thank you, Ms. Capps. And next, for an opening statement, another one of our healthcare professionals, which we have quite a few on this subcommittee, the gentleman from Georgia, Mr. Gingrey.
Well, Mr. Chairman, I thank you, and I want to thank, of course, overall committee chairman Waxman and former chairman Dingell, our ranking member, Joe Barton, and the ranking member on this health subcommittee, my colleague from Georgia, Congressman Nathan Deal. I also want to thank Dr. Todd Williamson from great state of Georgia, who is chairman of the Medical Association of Georgia, neurologist, a practicing physician from Lawrenceville, Georgia. Like my colleague from Texas, Mr. Chairman, I have a statement, too, that is fantastically written, and I want to just submit that for the record, but I actually didn't write it. My staff wrote it, and I want to give them all due credit, but I would like to ask unanimous consent to submit my written statement for the record, and I'll just make a few off-the-cuff comments. I agree with the President. I agree with the Democratic majority and many of my Republican colleagues that we need to do something, that health care in this country, while I believe is the best in the world, at the same time, I think that we have the best of times and the worst of times. And that is to say that while what we are doing with medical care in this country, I believe is the best in the world, the reason the statistics are so bad, as Ms. DeJette and others have mentioned, is the fact that we have 47 million people who don't have access to affordable coverage. And we have too many underinsured. And as a result of that, they put off getting needed care, going to the emergency room, going to their doctor. The availability is there, but they don't have the money, so they wait until things are so bad that it's really costly. And that's why it's the best of times and the worst of times. I think we need to look very closely, though, at what we can do to make sure that we improve our system. There is so much room for improvement. My thoughts have always been that if there's a real emergency to get something done by August the 1st of this year, even when our economy is suffering tremendously and we're trying to get that back on track, then maybe the money that we're spending, the $19 billion on having a fully integrated, comprehensive electronic medical record system is a direction in which we need to go, as well as a liability reform, which we have needed since California did it way back in the late 1970s. So there are many things, Mr. Chairman, that we can do. I think mainly, as I close my remarks, I just want to say that we don't want to destroy the marketplace, and we don't want to destroy the doctor-patient relationship, which is so important if we are going to continue to get the brightest and the best young people to go into this wonderful profession. And I'll yield back at this time, Mr. Chairman.
Thank you. Next, recognized for an opening statement, the gentleman from Texas, Mr. Gonzalez. Thank you. And next, gentleman from Pennsylvania, Mr. Murphy.
Thank you, Mr. Chairman, and thank you for doing another hearing on what we need to do with health care reform. I want to bring attention to an aspect here which I still hope that somewhere in this federal government we'll deal with, and that has to do with waste and inefficiency and its additional costs in this whole system here. We have and I do believe we have a great system of health care. I also believe that, unfortunately, sadly enough, we waste a lot of money in this whole system, and that leads to a lot of deaths. Let me just raise a few issues here, and here I also want to credit Dr. Gawande, who's here. There you are. Okay, I couldn't see you behind before. Thank you for this great article in the New Yorker. I hope I'm here later when you testify, but you point out a couple of things we need to pay attention to, and that is that there's a lot of money and a great many lives we can save by practicing health care, and along these lines, making sure government supports the doctor-patient relationships and doesn't get in the way. We look at statistics such as 90 to 100,000 deaths each year from infection, costs $50 to $52 billion. Programs like the Keystone Initiatives have been able to save a lot of lives and save a lot of money, which helps make health care more affordable. Using these numbers, so far this year, there's been 378,082 cases up to this moment to this hearing, 18,713 deaths, and a cost of $9,452,000,000. These are unacceptable. And as long as we continue to talk about quality, affordable, accessible health care, we have got to deal with these issues of true quality. But the list goes on and on. The underuse of appropriate medication, such as generic hypertensives, could save us another $3 billion a year if that was corrected. The underuse of medications for pediatric asthma could save us another $2.5 billion. One of the things that the government did in its infinite wisdom is said that the aerosol for asthma should no longer contain air that affects the ozone. So that was removed. New substances were put in that made the asthma medications brand name, raised the prices, and I don't know what that's done in terms of increasing admissions to hospitals since those studies have been reported. The overuse of medications such as antibiotics adds $8 billion to the cost. You also have to deal with untreated complications that come from mental illness that's associated with chronic illness. And yet what's happening in situations like this, we need programs that do real case and disease management to look at what kind of complications and problems are coming from underuse of medications, overuse of medications, referrals that are not needed, treatments that are needed. But instead we're talking about cutting programs like Medicare Advantage without looking at what Medicare Advantage does. To the extent that it works on prevention, disease management, and wellness programs, I hope this committee reviews what can be done in assisting those things. But this idea of saying that what we ought to do is just look at universal health care without looking at what we're doing for health care has got to stop. Along those lines, Mr. Chairman, an report came out in the last couple of weeks from the New England Healthcare Institute called Waste and Inefficiency in the U.S. Healthcare System, Clinical Care Comprehensive Analysis in Support of System-Wide Improvements. This report says that in our $2.3 trillion healthcare system, we have between $600 and $800 billion of waste that's hurting people, that if we remove this, it doesn't hurt healthcare, it actually improves healthcare. And that certainly helps meet our goal of affordable, accessible, quality healthcare. Mr. Chairman, I'd like to submit this to you and hope this is something that members of the committee would have at their access and perhaps include this in the record. It's a review of a lot of studies and the kind of things we should be looking at. I end with this. I've known a number of people who have been hurt and harmed in hospitals, and we don't usually do this, but I'm just curious. We have a good-sized audience out here. How many people here know of someone who went into a hospital or clinic and ended up getting an infection that made it worse? Raise your hand. I submit for the record, Mr. Chairman, there's a lot of lives we could be saving out here if we took efforts on this. I yield back.
I thought that we were going to have, like we did with the other day with Mr. Boyer, and you were going to get up with the chart, and I was going to feel like I was in a classroom again. But thank you. As I mentioned, we have quite a few health professionals. Mr. Murphy is a psychologist, and now we have our colleague from the Virgin Islands, who's also a physician, Ms. Christensen.
Thank you, Mr. Chairman, and thank you, Chairman Pallone and Ranking Member Deal, for bringing the subcommittee into the healthcare reform process early and planning the series of hearings that we're going to have so that we can fulfill our responsibility on this vital issue. And although I'm not practicing medicine today, I'm always going to be a physician, so I come to this from the same perspective of Dr. Williamson and others that I've heard speak to this today, Physicians, though too often blamed, are not the cause of the problem, but restoring the integrity of the physician-patient relationship can be a part of the solution, and I hope it will be. I put the blame largely, it rests with the reimbursement system and the failure of our country to provide universal coverage. But fixing this country's system of non-healthcare delivery and making it work for families will require far more than providing coverage. It must include addressing and ending our long history of unequal access to healthcare for racial and ethnic minorities, for women, for families in rural areas, for gay, lesbian, and transgender communities, and anyone perceived as different or who speaks differently or who's far enough away to be ignored, such as those of us who live in the territories. I've had a chance to look at some of the testimonies, and I just want to make some comments. Mr. Levine, I support increasing and expanding Medicaid, but I do share some of your concerns about Medicaid because increased access has not always resulted in better health outcomes. But I think that this is due in part to assumptions that discriminate against women, against people of color, and the poor. And that's why aggressively moving to increase providers of diverse backgrounds at all levels of our healthcare system has to be a part of designing a high-performance healthcare system. Mr. Hackbarth, the Commission has a heavy responsibility because so many important policy decisions rely on your recommendations, and I hope that you'll be able to assure me that the territories will receive equity in those recommendations. Dr. Gawande, I've really been impressed with not only your testimony, but what I've heard and read from you in the past. I'm concerned, though, that you don't reference the issue of disproportionate burden of disease borne by people of color and rural Americans in your testimony, or address the elimination of health disparities in your recommendations. Director Elmendorf, you are part of our congressional family, and I look forward to working with you, especially because I think we have a little work to do to convince you on the savings that really will be realized from universal coverage and prevention. So I look forward to that. And lastly, Mr. Ebler, I thank you for all of the work that the IOM has done on the issue of the uninsured. The Institute has clearly shown that this is not just a problem of those so unfortunate as not to have coverage, but it's a problem that increases the cost and undermines care for everyone. All of the vulnerabilities you list speak directly to health disparities, which must be a central focus as we work on healthcare reform if it's to be successful. So I look forward to all of the oral testimony and the dialogue that will follow, and I thank all of you for being here this morning.
Thank you. Next is the gentlewoman from Tennessee, Ms. Blackburn.
Thank you, Mr. Chairman. I thank you for the hearing, and I, along with my colleagues, am looking forward to a discussion of how we reform the healthcare system and what route we're going to travel here. Now, there are some who would like to see it move toward a government-run entity. And coming from Tennessee, where we have had the TennCare experience, and many would argue that the TennCare delivery system is probably the most broken healthcare delivery system in the nation, and that it is evidence, or should be of evidence to us, that a government-run system will encourage cost overruns, mismanagement, inadequate service, rationing or elimination or diminishment of care in certain areas of the state. And also, it has become evident from the TennCare experience that the estimated savings or the projected savings, the expected savings, were not evident because of increased usage and the other problems that I've previously mentioned. Rather than encouraging expansion of inefficient and ineffective government bureaucracy for a healthcare delivery system, I feel that we should be putting our time and energy focusing on how to foster competition, how we would actually reduce cost and provide choices for patients and consumers. I do believe in consumer-driven healthcare, which empowers patients to make the best choices for their individual needs, and to do that with a physician and also as they are choosing an insurance product that best suits them. And the medical savings accounts were mentioned earlier by Dr. Burgess and the impact that they have had. Transformation to consumer-driven healthcare and putting our focus there would create consumer demand for information on prices, on quality. It would also shift us toward greater transparency, which other of my colleagues have mentioned is a need that we have for the healthcare delivery system. Our constituents are telling us they would like to have access to information about quality, about outcomes, testing procedures, so that they can be an informed consumer. Mr. Dill had mentioned the need for medical liability reform. I associate myself with his remarks there, and as I welcome our witnesses today, we look forward to a robust debate and for continuing the hearings, Mr. Chairman, that you'll continue to have on this issue, and I yield back.
Thank you, Ms. Blackburn. Next is the gentlewoman from California, Ms. Eshu.
Thank you, Mr. Chairman, for holding this important hearing. We know it's important just looking at the first panel, the director of CBO and the chairman of MedPAC, and of course to be followed by the other witnesses. I think that this is really the easy part, is having the hearings. But the hearings are really the foundation for what we will come to do, and that is to reform our nation's healthcare system. I've been on this subcommittee for, this is my, I believe, 15th year. And what I've seen over the years are stops and starts. We've gone body part by body part to try and improve different parts of the system. Been successful in doing some of them. We have, I think, the world's finest doctors. I think we have the most innovative medical centers. We've progressed in leaps and bounds in biotechnology and the life science technologies. But our means of delivering care to patients is really inefficient. And it's costly, and it's often really counterproductive to maintaining good health. And this is now not only an issue for every American, and the American people are ahead of us on this. This is front and center an economic issue. The costs of our healthcare system in the country is just absolutely killing us. You know, we've increased at a rate that's double that of inflation, and that really should take everyone's breath away. So obviously, we need to reform. But I'm very mindful that this isn't called the healthcare industry for nothing. There are tens and maybe hundreds of thousands of players in this, stakeholders, and so we have a ways to go. But as the President said, in good times we didn't do it, in recession we didn't do it, after wars we didn't do it, now's the time to do it. I don't think we can afford to keep going this way, and I think the Congress will work its will. I think that there are going to be a lot of very good ideas placed on the table. Some will be somewhat startling because they will take down some of the old systems and bring about new ones. I'm open to all of those ideas, and I think that it is important for all of us to do that. And I don't think this is going to be done just by one party. We're going to really have to work together to get this done for the American people. So I look forward to it. And maybe this will be, I have confidence, I'm not going to say maybe, that in my 15th year on the committee, that we will get this done. So I welcome all the experts. We need the best ideas from the brightest and the best in our country. And I think that America is up for this. In fact, I think it's a demand of the American people that we do so. And when we do, I think that the rest of the world will watch and learn from us, because what America does is always a great lesson for the rest of the world. So thank you, Mr. Chairman, for the kickoff on this, and I look forward to the rest of it.
Thank you. Gentleman from Arizona, Mr. Shadegg.
Thank you, Mr. Chairman, and I want to thank you for holding this hearing. I want to jump off on the title. Making healthcare work for American families is the first part of the title, and I think that is essential. I think this Congress can no longer tolerate the problems with the current system, and therefore it must be reformed. The second half of the title is designing a high-performance healthcare system, and I believe we can do that, but I believe we have to do that by beginning with an analysis of what's wrong with the current system. As the gentlelady just mentioned, one of the things that's wrong with the current system is that costs have spun out of control. It's not exactly difficult to figure out why costs have spun out of control. We do not have a system in America that rewards the efficient delivery of health care. We have a system that rewards the inefficient system of health care. What we have is a third-party control system where your employer picks out your health care plan and your health care plan picks out your doctor. I suggested to a colleague this morning that would make about as much sense as if he said to me, okay, for the rest of my life, you, John, will pick out my homes, pick out my cars, pick out my suits, and pick out my shoes, and pick out everything else, pick out the food I eat, and I'll give those decisions to you. I suggest that if he gave those decisions to me and I tried my best to make him happy, I wouldn't make him happy. We've created a system in healthcare in America where we have divorced the consumer of the health good from the person paying or selecting that good. Right now, that system is a third-party control system where the employers pick the health care plan for their employees. Employees don't pick their own health care plan, and we've biased the system to say the only economic system that works is employer care. And oh, by the way, if your employer doesn't provide you care, we're going to encourage you to buy care, but we're going to punish you by saying that under the tax code you've got to pay a third more for that health care than your employer does if he buys it. So we've rewarded a system that gives the decision to somebody other than you to select your health care. And then we wonder why Americans aren't fit, why they don't eat right, why they don't control their blood pressure, why they don't control their cholesterol. I think if we look at the flaws in the current system, then it's easy to understand where we should go. We should not go to another third-party control. It seems to me it makes no sense to take third-party control by employers and plans and give that third-party control to the government. I got a flash. If I said to the government, you buy my cars in the future, you buy my house in the future, you buy my suits and my shirts, and you pick out the food I eat, the government wouldn't do any better job at making those decisions for me than my employer is. So what is the option? The option is, in fact, universal health care. This country has decided that nobody should go without health care, but we can give every single American health care and at the same time preserve choice. How do you do that? Well, you let the people that have the financial means to buy their own health care, buy their own health care, and you give them a tax credit to do that, and you say, go buy your own health care. But for every other American, you say to them, we're going to give you a stipend, we're going to give you a chunk of money, and you go make choices about your own health care. You buy a plan that meets you. Now, what about some person who doesn't respond and doesn't take up that plan? We put them in a pool and we say to them, if you need health care and you show up at a doctor's office, we're going to give you the health care. That way we've preserved choice. We've preserved people and consumers to make their own individual choices about health care. That will both bring down cost and bring up quality, and it's a system we can implement and will cover every single American. And I hope when we begin to design a system for health care in America, we look at the President's 8 points. I think every single one of those fits with what I've just described, and I believe we can do it, and we can do it for every single American. And I thank the gentleman and yield back the time I don't have.
Thank you. The gentleman from Maryland, Mr. Sarbanes.
Thank you very much, Mr. Chairman. And I want to congratulate you on now launching this discussion on health care reform, much needed, and looking forward to the various panels that we see. If and when, as Congresswoman Schakowsky said, we achieve health care reform, it'll only be partly because of the arrival of some of the newer members in recent years. It'll be mostly because of the incredible work that you and others, Chairman Waxman, Chairman Dingell, and other distinguished members of this committee have performed for so many years. It's a great committee with a great challenge before it. The broken healthcare system that we're all alluding to is one that really has two sets of victims. I had the privilege of working for almost 18 years as a lawyer with hospitals and physicians and clinics and nurses and other providers. And I say privilege because I've never witnessed the level of professionalism that I have when it comes to people that work so hard in our healthcare industry every day on the provider side. And they're one of the victims. They're one of the sets of victims here in this broken healthcare system because they're carrying it on their back right now. The other set of victims, of course, are patients and the consumers of healthcare. And, you know, most Americans don't really have any idea what the perfect design or even close to good design of our healthcare system will be. But for millions of Americans who are uninsured and underinsured, what they do know is that they get up every morning and they can't breathe. They are burdened by a corrosive anxiety that eats away at their self-dignity and eats away at the stability of their families. And that's why we've got to get this done. And I look forward to the hearings that are coming forward, and I look forward to getting health care reform done in a timely fashion. I yield back. Thank you.
Thank you. The gentleman from Pennsylvania, Mr. Pitts. Gentleman waves. Gentleman from Ohio, Mr. Braley.
I was confused by the reference to Ohio, but I will be glad to.
Did I say Ohio? I meant Iowa. I apologize.
Thank you, Mr. Chairman, and thank you for holding this important hearing. I'm looking forward, like many of the other members of the panel, to helping this subcommittee address health care reform over the coming months. But as we look at ways to design a high-performance health care system, I want to draw everyone's attention to two issues that directly impact the overall performance of this system. One, geographic inequity in Medicare reimbursement, and two, the considerable variation in health care quality across this country. The current system that we have in place has built-in inequities that result in the lack of access to care for residents in many rural states like Iowa. An example of this can be found in the Geographic Practice Cost Indices, or GPCIs. These antiquated figures ensure that some parts of the country receive drastically lower Medicare reimbursement rates than other parts, and have led to a tremendous shortage of healthcare providers in certain parts of the country. In an attempt to achieve some leveling of geographic inequity in physician reimbursements, the Medicare Modernization Act of 2003 established a temporary floor of 1.0 for the work GPCI, which helps level the playing field for physicians in Iowa and other rural states. Congress has had to extend this floor repeatedly, yet the floor on the work GPCI still does not go far enough. Despite the well-documented deficiencies of Iowa's health care system, Iowa health care providers still lose millions of dollars because they choose to care for Medicare patients. Last Congress, I introduced the Medicare Equity and Accessibility Act, which addresses the GPCI problems. I will continue fighting for a permanent work GPCI floor as well as a practice expense GPCI floor, but frankly, this is only a Band-Aid for a broader problem. While Iowa's access to care ranks low, the state's quality of care consistently ranks right at the top. Iowa physicians, hospitals, and healthcare personnel are unrivaled and are a primary reason why Iowa consistently ranks in the top 10 healthiest states. Unfortunately, the way our current health reimbursement system is set up, it is not based on the quality of care provided, but instead incentivizes quantity of care, which results in considerable variation in quality around the country. I hope this committee takes a serious look at proposals to incentivize quality and efficiency, such as value-based purchasing models. This fundamental shift in our reimbursement system would lead to a tremendous improvement in the quality of American health care. Instead of a business model that encourages physicians and hospitals to get patients in and out as quickly as possible, we'd have a system that encourages them to make sure the patient is healthy. That's what really matters. By including efficiency measures and value-based payment programs, we can keep costs down for our patients in our federal payment programs. By aligning incentives across hospitals, programs, and physicians, we can achieve greater interoperability. And by encouraging care coordination, such as through the medical home concept, we can further deliver better and more efficient health care. So I want to thank you, Mr. Chairman, for tackling the important issue of health care reform, and I want to thank all the witnesses for spending time with us today.
I thank the gentleman from Iowa. And next is the gentleman from Michigan, Mr. Rogers.
Mr. Chairman, I'll submit my statement for the record in lieu of questioning time.
Thank you. Next is the gentlewoman from Illinois, Ms. Schakowsky.
Thank you, Mr. Chairman. In some ways, I think I've been waiting for this hearing all of my adult life. As my goal as a public official, I will die a happy woman if it says on my tombstone or urn or whatever they do with me, that she helped bring health care to all Americans. And I think this is the first of a process that I hope moves rather speedily. The President has targeted actually signing the bill after the August recess, so we have a lot of work to do. I think it's a total embarrassment that the United States of America, the wealthiest country in the world, does not provide health care to all of its people like every other country in the industrialized world. It's a moral issue, it's an economic issue, and one that that may be controversial here in this body, but actually outside of this room and in the country, most Americans are ready for change, they're ready for big change, and they see an important role for government in that change. Anyone who thinks that we have good access to health care doesn't live in the real world. In my state alone, 1.8 million people have no health care, but that's just the beginning, the tip of the iceberg. The number of people who are uninsured, over half of Americans say that they have delayed health care or foregone health care because they can't afford it. As people lose their jobs, 650 people every day in Illinois right now losing their job, 14,000 people losing their health insurance every single day. This is a crisis that cannot wait to be solved. So I want to make one other point. There's been a lot said about having a public health insurance option, the choice, which 73% of Americans say they'd rather have a choice of a public option or a private option. If their private plan works for them, fine. But I would say it's the private health insurance industry that has some explaining to do. The Medicare is one of the people come into my office and say, I can't wait until I'm 65 years old. I am sick right now, and I'm looking forward to my 65th birthday so that I can actually get the health care that I need. And persons with disabilities and seniors have been lifted out of poverty because of this successful social insurance program along with Social Security. The Commonwealth Fund did a study and found that designing a health care system that covered everyone, including a public health insurance option, over 11 years would save $3 trillion to do that. In 2008, private market health insurance premiums rose by 5% to nearly $12,700 for a family of four, $4,700 for individual coverage, and so private insurance is increasingly out of the reach of Americans. And so what the President has proposed is to have this option of the public health insurance program or a private. I think that that ought to be a centerpiece of any plan that we adopt. And I yield back. Thank you.
Gentleman from Texas, Mr. Green.
Thank you, Mr. Chairman, and I appreciate the time. And following my colleague from Illinois, I know your current senator was concerned about what was going to be on his tombstone. I would hope it would be, that's not in Illinois an issue. But I want to, like my colleague from Illinois, though, having moved to the Energy and Commerce Committee in '97, this is one of the most important hearings I think we can have because it's a start of on what we're going to do in this Congress to change how health care is provided in our country. I come from a state of Texas where we have the highest percentage of uninsured in the country, that have the highest number of uninsured in the country. There are a lot of reasons for that. And I'm glad the President also in his budget released a couple of weeks ago is planning to take action on health care. I also like the principles he laid out for us last Thursday. Instead of sending down a large piece of legislation where they try to dot all the I's and cross the T's, that's Congress's job, is to draft the legislation. Give us the goals, and we will do everything we can to get to it. Again, this is our first hearing on, we currently have 47 million people uninsured in our country, and overall health care is consuming ever-increasing amount of our resources. Health care expenditures are now 16% of GDP, with the rate going to maybe 20% by 2017. Unfortunately, we're paying more for the cost of health care, but seem to be receiving less and fewer people having access to quality and affordable health care. The current economic times make it even harder for individuals that are uninsured simply because their companies can't afford health premium or their employers can't afford, the companies can't afford health insurance or their employees can't afford to pay their percentage of the premium. We recently passed the American Reinvestment and Recovery Act, which I strongly supported, and extended COBRA subsidies to individuals who lost their jobs, which is wonderful for those who had insurance before they lost their jobs. Unfortunately, in blue-collar districts like I represent, most individuals never have access to the health care in the first place because they are in low-wage jobs. Too many individuals in our country are unemployed or uninsured and are all too often end up in the emergency room with very costly medical issues that could have been averted with access to primary and preventative care. We can't continue to shore up a health care system with short-term fixes instead of long-term solutions. We cannot continue down the path in which is costly health care and more uninsured. I'm glad we're taking our first step in addressing the health care crisis, and I welcome our witnesses today to be the lead-off witnesses. And I have a saying in Houston, we have one of the greatest medical centers in the world, the Texas Medical Center. On a clear day in Houston, we can see the medical center, but most folks in my area can't get to it because they lack health care unless it's through our public hospital system. And with that, Mr. Chairman, I yield back my time.
Thank you. Gentleman from Ohio, Mr. Space.
Thank you, Mr. Chairman. I look forward to working with you as we begin this comprehensive debate on how we deliver health care in America. I think as we move forward, many of my colleagues have raised very important and legitimate issues. The health IT program, coordinated care, preventative measures, rewarding positive lifestyles, punishing negative lifestyles. But one element that I'm hoping we won't forget about is the importance of cure, curing disease. There has not been a significant breakthrough on a cure in this country since polio was cured. And cures are within our grasp. And not only do we have a moral obligation to alleviate or mitigate human suffering, cures end up being a very economically effective way of handling the healthcare crisis. In 2007, this nation spent $178 billion on one disease, diabetes. That's more money than we spent in Iraq. With a small percentage of those monies that were spent in that 1 year and that are spent every year at an increasing rate, we could cure the disease within 5 to 10 years, either naturally or artificially, providing every type 1 diabetic with a closed-loop artificial pancreas, mitigating and eliminating the expenditure of trillions of dollars over the next 30 years. That's one disease. Imagine what we could do if we invested in a cure for cancer, for heart disease, for liver failure, even for things like autism. We are, Mr. Chairman, I think, remiss in failing to address cures with an aggressive posture. And I'm hopeful that that will be a part of this debate as we move forward. In the end, I think we all share a common goal, and that is providing affordable access to quality health care. I don't care how we get there, but we have to get there. I yield back.
Thank you. The gentlewoman from Wisconsin, Ms. Baldwin.
Thank you, Mr. Chairman. Addressing our health care crisis is the issue that brought me to public service in the first place. So I do want to truly thank you, Mr. Chairman, for holding this hearing and getting us started on this enormous task that's before us. And I want to thank all of our witnesses in advance because your expertise is going to be invaluable to us in the process. In a report released last week on the series of health care communities discussions held around the country, the Department of Health and Human Services found that more than anything else, Americans want a system that is fair. No matter what your circumstance or background, the American health care system should perform well for you too. To that end, I will address briefly the three major issues that we all know so well: access, quality, and cost. As we will hear today, being shut out of the system is deadly. Uninsured adults are 25% more likely to die prematurely than insured adults. And if they have a serious chronic condition, the situation is worse. And every day, more and more people are falling into the ranks of the uninsured. Erosion of employer-based coverage and the challenges of the individual market demand our immediate attention. A high-performance healthcare system, by definition, must also deliver quality care. And I strongly believe that providers can use performance measurements to drive quality improvements. A leader in this respect is a hospital in my own district, the University of Wisconsin Hospital and Clinics. They have led the way in several nationwide efforts to benchmark performance. They consistently rank among the top 5 academic medical centers in the country according to 5 key metrics: mortality, effectiveness of care, safety, equity, and patient-centeredness. These efforts at public reporting and the sharing of best practices demand excellence from our healthcare system. Lastly, I want to quickly address the issue of cost. We are operating under an assumption today that at first glance seems implausible, that we can pay less for our health care and get more from it. And yet the data is clear. Our current system is wildly inefficient. Some of the highest cost regions produce poorer patient outcomes. Some of our lower cost regions produce some of the highest outcomes. I'd like to personally thank our witnesses on our first panel today for your invaluable assistance in helping us solve this problem. MedPAC has recommended significant restructuring of the payment system, suggesting that we pay for care that spans across provider groups and types and time in order to hold providers accountable. For me, health reform is an endeavor that is both intellectual and emotional. As a member of Congress, I know that we must control the unsustainable spending in our healthcare system. As a representative of the men, women, and children in the 2nd District of Wisconsin, I know we must fix our broken system so it can reach and serve everyone. Again, thank you to our witnesses today for being here, and Mr. Chairman, for beginning our work in earnest.
Thank you. The gentleman from Arkansas, Mr. Ross.
Thank you, Mr. Chairman, and like Dr. Burgess and so many others, I had a prepared statement that I'll submit for the record, but most of what I said in that has already been said. But I would like to speak for a moment from experience and from a rural perspective, if I may. I served for 10 years on the state health committee in Arkansas in the state Senate, and that is where I learned that any real reform had to happen at a national level, and it inspired me to run for Congress and to seek this committee and seek this subcommittee. I chair the Blue Dog Healthcare Task Force, and it's the rural perspective I took to the Healthcare Summit at the White House last week in our breakout session. My experiences as a pharmacy owner, someone married to a pharmacist, and being from a small town, I can tell you I've seen too many people walk through the doors of that pharmacy that could not afford a $30, $40, or $50 medication. And living in a small town, I would learn where they were in the hospital a week later, running up a much higher bill, if you will. We have got to make health care affordable and accessible and available for everyone. My hometown is much like my district. I represent 150 towns, and half my constituents don't live in any of them. They live down this gravel road or that gravel road, and it's important that those folks have access to health care too. My hometown is a good representation of my district. It's 3,600 people when I'm home, and 2 traffic lights. Just a few years ago, we had 6 doctors, 5 pharmacies, and a hospital. Today, we've got 3 doctors, 2 are over the age of 60, 2 pharmacies, and no hospital. The nearest hospital is in Hope, Arkansas, 16 miles away, and now it's struggling to keep its doors open. If it closes, we will be 40 miles from the nearest hospital. The leadership of the hospitals in Hot Springs, Arkansas, the largest town in my district, wanted to meet with me recently. And they wanted to tell me how Hot Springs cannot attract doctors. It's got a high retirement age population, a lot of sick folks, it's on a lake, and it's in a national park. By Arkansas standards, it is a prime place to live, and if we can't attract doctors there, what about these other 149 towns that are much smaller and much more rural? So I would ask that rural health care be an important part of any reform, and I can't help but think, Mr. Chairman, back to the days of Orrin Harris. His portrait's right here. He comes from my district. He chaired this committee. He began chairing this committee 5 years before I was born. And he was trying to reform health care then. That was 53 years ago. And I hope that we can get it done and get it done right this time. And with that, Mr. Chairman, I pledge to work with you. Please keep rural health care an important part of any reform debate. Thank you, and I yield back the balance of my time.
Thank you. The gentlewoman from Florida, Ms. Castor.
Thank you, Chairman Pallone, for this first in the series of hearings to reform health care in America and make it more affordable for businesses and families. You know, together with President Obama, we've already hit the ground running to improve the health care of Americans with the enactment of the landmark Children's Health Bill, the S-CHIP. The American Recovery and Reinvestment Act also provides much-needed assistance in COBRA, for COBRA payments for folks who have lost their jobs, and aid to states for Medicaid. We're not going to let our families fall through the safety net. Now, our larger challenge is to confront health care reform. And I believe we can tackle it with a commitment and determination to develop a quality, affordable health care options for Americans. In my home state of Florida, where we have the second highest rate of uninsured, families and businesses have been clamoring for access to affordable health care well in advance of the economic downturn and the rise in unemployment and home foreclosures. In Florida, it is estimated that more than 6 working-age Floridians die each day due to a lack of health insurance. The inability to afford basic health care poses a major threat not only to the well-being of families, but to our economy as a whole. Nearly half of home foreclosures in 2006 were caused, at least in part, by financial issues stemming from a medical problem. As President Obama noted just last week, the cost of health care now causes a bankruptcy in America every 30 seconds. Now, there will be many outstanding ideas, and I look forward to hearing from our witnesses. I believe particular focus and attention must be paid to the primary care system and preventative medicine. Also to the healthcare professions, especially this very arbitrary cap on physician resident slots that penalize states that have high growth and high population. Nursing shortages, Medicare reform. With everyone's help and my colleagues' expertise, I'm confident that we will reduce health care costs for families and businesses and hopefully our national budget. The time to act is now. I yield back my time.
Thank you. The gentlewoman from Ohio, Ms. Sutton.
Thank you, Mr. Chairman, for holding the first of many important hearings on health care reform. Health care reform is a critical component to our economic recovery and our nation's competitiveness. As health care costs rise, neither employers nor employees can afford them. And if one loses their job, the situation is even more daunting. I'd like to begin today talking about a family in my district, the Lee family. Mr. Lee has always had health insurance through his job, but when his company laid him off last year, he and his family lost coverage. Mrs. Lee tried to get coverage through her job, but she didn't qualify because she was a part-time employee. Now, having a family with medical problems ranging from diabetes to degenerative joint disease and being without health insurance has created a very, very difficult problem for the Lees. And unfortunately, Mr. Chairman, this is a situation that's familiar to far too many Americans. The Lee family is certainly not alone. In Ohio, there are over 1.2 million people without health insurance. And Mr. Chairman, this causes an amazing outcome. According to Families USA, 2 Ohioans die each day because they lack health care coverage. I want to say that again. In Ohio, 2 Ohioans die each day because they lack health care coverage. Many Americans have to forego health care in order to put food on the table or keep a roof over their head. That is unacceptable. Our health care system must be reformed, and as a member of this subcommittee, I look forward to working with my colleagues and the American people to make it happen finally. And I look forward to hearing from our panelists today about this important issue and their insight into how we might go about making this become a reality. I thank you, and I yield back the balance of my time.
Thank you. The gentleman from New York, Mr. Engel.
Well, thank you for holding, Mr. Chairman, this hearing today on making health care work for American families. It's clear to so many of us that our health care system is broken. For years, we've been talking about the 47 million growing uninsured Americans and 25 million underinsured Americans, and it is apparent that some people have come to accept this tragedy as a fact of life, that some people are fortunate to have health coverage, and some people, millions and millions of people, aren't. So too bad for them. In truth, it has often been said, everybody does better when everybody does better. We can do better. The status quo is no longer acceptable. In the first 2 months of the Obama administration, we made significant strides toward improving our current health care system. Our reauthorization of the state children's health insurance program provided health care coverage for 11 million children, preserving coverage for the roughly 7 million children already covered by S-CHIP, and extending coverage to 4.1 million uninsured children who are eligible for but not enrolled in S-CHIP and Medicaid. We made a solid investment in modernizing our health care system in the stimulus by making key investments in health information technology. Wide-scale adoption and implementation of health information technology will be a fundamental part of any true health reform bill. The $19 billion designed for HIT will eventually enable our health care system to save billions of dollars, reduce medical errors, and improve quality of care. Many of the measures included in the stimulus, ranging from extra Medicaid funding for states to subsidizing COBRA insurance for unemployed workers, will help to stop the bleeding during this terrible recession. Long-term, though, our health care delivery system requires a comprehensive implementation of sustainable reforms in order to succeed. The President is off to the right start with his commitment to health reform. His $630 billion down payment towards health reform, coupled with the administration's 8 principles, will guide Congress in our joint efforts to revamp our health care system. With the United States paying more than $2 trillion a year for health care, we should ensure that we are getting what we're paying for, a world-class health care system for our nation's hard-working citizens. And yet, it is clear that our payment systems are flawed. As MedPAC has noted in its testimony today, Medicare's fee-for-service payment system rewards more complex care without regard to the value of this care. Bizarrely, for those with multiple ailments, coordination among providers is not encouraged financially by Medicare, where clearly coordinated care would result in improved health conditions. Mr. Chairman, thank you again for holding this hearing. You've really been a champion in pushing these reforms, and I commend you for it. I look forward to the work ahead of us this spring and summer on reforming and designing a quality health care system. And I yield back the balance of my time.
Thank you. Gentlewoman from California, Ms. Harmon.
Thank you, Mr. Chairman. I'm very pleased to be a new member on this subcommittee, though not new to these issues. I am the sister and daughter of physicians, and I recall very well, half a century ago, how my father handled his general practice of medicine. He was the neighborhood physician. He made house calls most evenings. He served 3 generations of patients in a small group practice in Culver City, California, during the time he practiced medicine. I was very proud of what he did, and now I look back on it and it seems an Ozzie and Harriet alternative reality. We can't go back there, Mr. Chairman, and we surely have to grapple with the problems described by so many of our colleagues this morning. But I must commend you for the panels in this opening hearing today, and I especially want to mention Doug Elmendorf and congratulate him in his new role as Director of CBO. He has been a valuable asset to many of us as we have tried to grapple with budget issues, and what I think he brings to this is obviously an understanding of the cost piece of health care, but also great compassion for the need to extend coverage to as many as possible in our country. So I commend you for this hearing. I commend our witnesses, and count me in on all plots to make a huge down payment on solving this problem this year. I yield back.
Thank you. And I believe that concludes our opening statements. And so we'll now turn to our witnesses. And for our, well, first of all, let me welcome the first panel and the two gentlemen. And let me introduce you. On my left is Glenn Hackbarth, who's the chairman of the Medicare Payment Advisory Commission, or MedPAC. And to my right is, or to his right, is Douglas Elmendorf, who's director of the Congressional Budget Office. And we're really looking forward to your testimony. I've kind of looked at some of the written testimony, and you deal with very effectively with new ways of doing things and the whole cost efficiencies, which are so important to us. We'll start with Mr. Hackbarth.
Thank you, Mr. Chairman and Ranking Member Deal. I appreciate the opportunity. Many of my comments in my opening statement will echo themes that have already been heard. Let me begin with a brief definition of health reform, at least in my mind. Health reform equals expanded coverage plus lower cost growth while maintaining or even improving quality of care. MedPAC's focus, as you well know, is on the latter set of issues. In particular, using payment policy to improve the efficiency and the effectiveness of the care provided to Medicare beneficiaries. And in some quarters, this has been labeled moving the system toward high performance. Let me start by emphasizing that the U.S. healthcare system has tremendous resources in the professionals who serve in that system. I've been fortunate in my career to work with talented physicians and advanced practice nurses and psychologists and other professionals, and I know what talent and commitment they bring to their work. The problem we have is that Medicare's payment systems and those of most private insurers reward more care, more complex care, without regard to the value of that care to the patients. But equally important is that Medicare's payment systems enable what we've referred to as siloed practice, whereby individual clinicians and organizations act independently of one another, even while caring for the same patient. Too often, efforts at coordination and integration of care are sporadic, and where they occur, they're testimony to the commitment of individual professionals. They're not inherent in the system itself. The result is that care is all too frequently fragmented, duplicative, and gap-filled, and on occasion, even conflicting, as is the case sometimes with adverse drug interactions. Care of this sort isn't just expensive, it's dangerous. And it's dangerous in particular for patients with multiple complex illnesses, which is a common problem, as you well know, in the Medicare population. In the last several years, MedPAC has recommended a series of changes in Medicare payment policy that we believe would help move health care to a higher level of performance. And let me just quickly mention some of those recommendations. First is increased payment for primary care services, and perhaps a different method of paying for primary care services as is embodied in the idea of a medical home. Research demonstrates conclusively, in my view, that a strong primary care system is the foundation of a high-performance health system. In the United States, at this point, our primary care system is weak and rapidly deteriorating. Second recommendation has been that we begin providing confidential, episode-based feedback to physicians about their practice so that they can better understand how their practice compares to their peers, both in their local area and in their specialty. Third, we've recommended authorization of what we refer to as gain sharing between physicians and hospitals. The goal here is to encourage collaboration between physicians and hospitals, both in reducing cost and in improving quality of care. Next, we've recommended reduced payments for hospitals experiencing unusually high levels of potentially avoidable readmissions. About 18% of all Medicare admissions are followed by a readmission within 30 days at a cost of about $15 billion per year. A sixth recommendation is a pilot of what we've referred to as bundling, whereby payment for hospital and physician services provided during an admission would be combined into a single payment and perhaps combined with payment for post-acute services as well. Next, we've proposed reforms in the Medicare Advantage program so that participating private plans are engaged in promoting high performance in health care instead of offering plans that mimic traditional Medicare except at a higher cost. And last, we've urged public investment in comparative effectiveness research, which the Congress has already acted on in the Economic Recovery Act. This week at our MedPAC meeting, we will also be considering the potential for what we've referred to as accountable care organizations, organizations that assume clinical and financial responsibility for a defined population of patients. We'll be trying to figure out methods to pay such organization that could reward efficiency and reduce cost for the Medicare program. Let me close with two quick cautions about the challenge ahead of us. First of all, changing payment systems, and especially trying to do so quickly, requires a lot of resources. And I am very concerned, the Commission is very concerned about the level of resources that CMS has to pursue this agenda. A second caution is that while striving for payment reform, as important as it is, as vital as it is, we must also apply steady, indeed perhaps increasing pressure on unit prices under Medicare's existing payment systems. Thank you very much, Mr. Chairman, and I look forward to the discussion.
Thank you, Chairman Hackbarth. Director Elmendorf.
Thank you, Chairman Pallone, Ranking Member Deal, members of the subcommittee. I appreciate the invitation to talk with you today about the challenges and opportunities that Congress faces in trying to make the healthcare system more efficient so that it can continue to improve Americans' health but at lower cost. Policymakers could seek to improve efficiency by changing the ways that public programs pay for healthcare services or by encouraging such changes in private healthcare plans. In both sectors, these changes could in turn exert a strong influence on the delivery of care. To assist the Congress in its deliberations on this topic, CBO released last December a report titled Budget Options for Healthcare. Drawing in this report, my testimony makes three key points. First, a substantial share of spending on healthcare contributes little, if anything, to the overall health of the nation. Second, reducing unnecessary spending without also affecting services that do improve health is challenging. But many analysts would concur with the importance of providing stronger incentives to control costs and generating and disseminating more information about the effectiveness of care. Third, despite broad support among analysts for moving in these directions, there is substantial uncertainty about the effects of many specific policies. And many policies might not yield substantial budget savings or reductions in national health spending within a 10-year window. Let me discuss these points briefly in turn. First, as you know, spending on healthcare has grown much faster than the overall economy for decades. This imposes an increasing burden on the federal government, for which the principal driver of the unsustainable budget outlook is growth in per capita health costs, not aging. It also imposes an increasing burden on the private sector, where the growth of health spending has contributed to slower growth in wages, because workers must give up other forms of compensation to offset the rising costs of health insurance. When confronted with these costs, ever more firms and families drop their health insurance coverage. Concerns about the level and growth of healthcare spending might be less prominent if that spending was producing commensurately good and improving health. Unfortunately, substantial evidence, detailed in my written testimony, suggests that more spending does not always mean better care. The second main point is that many analysts would concur with the importance of providing stronger incentives to control costs and of generating and disseminating more information about the effectiveness of care. Many analysts would agree that payment systems should move away from a fee-for-service design and should instead provide stronger incentives to reward value. These incentives can be created in a variety of ways, including fixed payments per patient, bonuses based on performance, or penalties for substandard care. However, the precise effects of these policies are highly uncertain. Many analysts would also agree that the current tax exclusion for employment-based health insurance, which exempts most payments for such insurance from both income and payroll taxes, dampens incentives for cost control because it is open-ended. Those incentives could be changed by restructuring the tax exclusion in ways that would encourage workers to join plans with higher cost-sharing requirements and tighter management of benefits. Moreover, many analysts would agree that more information is needed about which patients work best for which patient, which treatments work best for which patients, and about what quality of care different doctors, hospitals, and other providers deliver. But absent stronger incentives to improve value and efficiency, the effect of information alone will generally be limited. Third, many steps that analysts would recommend might not yield substantial budget savings or reductions in national health spending within a 10-year window. There are a number of reasons for this. Again, further details in my written testimony, but briefly, in some cases, savings materialize slowly because an initiative is phased in. In other cases, initiatives that generate savings, such as prevention efforts or disease management, have costs to implement. In some cases, the federal budget does not capture the reductions in national health spending. In other cases, new structures for healthcare delivery improve health, but do not provide incentives for reduced costs. And in yet other cases, limited evidence about the effects on efficiency is available. Let me conclude with two general observations. One is that given the central role of medical technology in the growth of health spending, slowing spending over the long term will probably require decreasing the pace of adopting new treatments and procedures or limiting the breadth of their application. Such changes need not involve explicit rationing, but could occur as a result of market mechanisms or policy changes that affect the incentives to develop and adopt more costly treatments. The other observation concerns the urgency of healthcare reform. In contrast with the situation in the economy and financial markets, our system for delivering and paying for healthcare is not fundamentally different this year from last year. However, very few analysts think that the relatively gradual pace of change in healthcare is an argument for deferring reform. On the contrary, our current health system evolved over years and decades, and the thoroughgoing changes needed to substantially improve efficiency will take years and decades to come fully to fruition. Nearly all analysts think those changes should begin soon. Thank you.
Thank you. So we're going to have questions now from the members, 5 minutes. In some cases more, I think, if the members passed on their opening. I wanted to start with Mr. Elmendorf because of the issue of primary care. Many experts, such as Dartmouth researchers, maintain that a lack of access to high-quality primary care contributes to inefficient care and geographic variations around the nation. And they say that if we invest more in primary care to improve quality and lower costs, that would be one of the main efficiencies that we could achieve. And I have to say that, when you listen to President Obama at the summit last Thursday, he stressed, this whole idea of health inflation and that somehow we have to curb the growth in costs. I think Karen Ignani from the health insurance trade group or whatever actually at my breakout session talked about, curbing the growth or the inflation, if you will. And I have to give you, personal experience. I mean, there's a couple of my staff people in my office in New Jersey have, Cadillac health insurance, Blue Cross, whatever, and have had a problem getting a primary care doctor. On 2 occasions, because they couldn't get a primary care doctor, ended up going to an emergency room for, something that really wasn't necessary to go to the emergency room. And, I keep saying, we keep talking about people who have no insurance that go to the emergency room. Well, what about a congressional staff person who has insurance and can't get a primary care doctor and goes to an emergency room? So my question is, with regard to primary care, and particularly within the Medicare program, I mean, you mentioned this patient-centered medical home as an option. But talk a little bit more about what you see in terms of enhancing primary care and how important that is to the overall system in terms of cost efficiencies and trying to make a better quality system.
Mr. Chairman, many analysts have worried for some time that our system does not reward primary care physicians the same way that it rewards physicians in specialties. And if you look across the country and compare medical centers that are seem to be delivering very efficient medical care in the sense of low cost, but medical care of high quality, those medical centers tend to have higher relative numbers of primary care physicians to specialists. And I think that sort of evidence is the basis of some of MedPAC's recommendations in this area. The options that CBO looks at, we've looked at a number of them regarding ways to empower or reward primary care physicians. One is a proposal for establishing medical homes in which all Medicare recipients are assigned to primary care physicians, and those physicians then oversee the way in which those patients receive care from other providers. The crucial issue I think many analysts would agree that sort of focus on primary care physicians would lead to greater coordination of care, fewer duplicative tests, and better health. Whether it leads to cost reductions depends, in our judgment, crucially on the incentives that those primary care physicians receive. So one approach to this is to provide those incentives to primary care physicians by rewarding them for reductions in spending while maintaining high quality. And the effectiveness of those sorts of provisions, so we look at some other provisions, there are other ways, in addition to medical homes, in which primary care physicians can be empowered to make decisions and to coordinate care. But again, it's crucial that if one wants to reduce federal outlays, that they have incentives focused on not just recommending a whole range of additional services that aren't necessary.
Okay. I want to get a second question, but I appreciate that. You know, Mr. Elmendorf, I want to ask Mr. Hackbarth this. Mr. Elmendorf talked about how, you might limit the pace of new procedures, not through rationing, but through, some other means. The president, I commend him. He's been so honest about everything in terms of budgeting. He came up with this $600 billion reserve fund. He said, look, that's only going to pay for half the cost of covering everyone. Within that, he said, half of it can be done through cost efficiencies. The other half, you're going to need a new source of funding. All these things are very controversial, but he doesn't hesitate to bring them up, to his credit. But, when you talk about these cost efficiencies, which is MedPAC is, really the key, we get, as you know, you came out with your report, I guess, a week or so ago. And, I mean, every time it comes out, the phone rings endlessly in my office because, they see you as like the ultimate bad guys that want to cut back on all the providers and on the imaging and everything else. So, the question is, I mean, how realistic is this? I mean, can we really pay for all these things through cost efficiencies? I mean, are we really going to be able to pay for a quarter of the cost of expanded coverage through these cost efficiencies? Can we pay for even more than that because the president's reserve is only half? Can we, can you move towards what Mr. Elmendorf said and, actually limit new procedures without having an uproar and without, I'm not asking you to, I know you're not a politician, but I just wanted you to comment on that if you could. It's endless, obviously, but.
Yeah. Well, let me break it into two parts. First, addressing the issue of new technology, how it's introduced to the system, how it diffuses. In terms of slowing the rate of increase in long-term health care costs, that's going to be a principal focus of our efforts. And that's why we strongly supported the idea of a large-scale public investment in comparative effectiveness information. We don't think that that necessarily means that you have to have a single entity making rationing decisions. Indeed, what we've advocated is creating more information so that individual physicians and their patients private health plans, public health plans, and others can more thoroughly evaluate the choices that need to be made. And we've advocated that the choices continue to be made on a decentralized basis, not in one federal bureaucracy. But we can't make sufficient progress on this technology issue without far better information than we have had in the past. The private market has not and will not produce that information, so public investment is very welcome in that. Having set aside the technology issue for a second, there are very large inefficiencies in the delivery of care, many of them, most of them, rooted in how we pay for care. Realistically, though, as you say, Mr. Chairman, when you change those payment systems, you are doing two things. One, you're redistributing income across different types of providers, sometimes geographically. In addition to that, you're bumping up against really entrenched ways of behaving, cultures that exist within these organizations. And we need to be realistic about how quickly those things will change. They will not change overnight. But to me, what that does is emphasize how important it is we start today and not delay these things further and further into the future. The decisions will be controversial. You're going to need to make those decisions. We'll provide you the best information and analysis we can to support you in that effort.
Thank you. Mr. Deal.
Thank you. As I listen to opening statements in your testimony, two words come to mind, and I want to focus on those two words. Much of what you've just responded to in the chairman's questions, you will respond, I'm sure, the same to mine, but maybe you want to elaborate further. The two words are cost and results. Now, they're not always equated with each other. In fact, we know the statistics. First of all, cost. And I think we all recognize that much of the escalation in cost has been related to new procedures, new treatments, new pharmaceuticals. And Mr. Elmendorf, a partial quote from your testimony about 2 weeks ago to the Senate Finance Committee, you said reducing or slowing spending over the long term would probably require decreasing the pace of adopting new treatments and procedures or limiting the breadth of their application. Now, I've got two questions. My first question is, are there ways to encourage doctors and patients to take into account the cost when making a treatment decision without requiring third parties such as the insurance company or other people, including Congress, to make those decisions for them? So that's the question on cost. The second question relates to results. Now, comparative effectiveness is a term that has sent shockwaves through the medical delivery community, as you're aware. Now, when I think of cost comparative effectiveness, I think it can be defined as either the mode of treatment which is generally most effective, which is, I think, the equivalent of a protocol or best practices, but it can also be interpreted as a limitation of treatment, which is where the scary part of rationing comes in. And in that regard, my second question is, what steps can we take to ensure competitive effectiveness research helps improve patient and provider decision-making while avoiding the blunt, centralized access restrictions? My two questions.
So on your first question, Congressman, there are several steps that could be taken to increase incentives for providers and patients to focus on value, on getting results, not just on spending money. One is, mentioned in my testimony, is changing the tax exclusion for health insurance so as not to be open-ended, so that we don't provide essentially a federal subsidy at fairly high rates for people to get ever more expensive policies. Changing that would induce people to be more, and firms to be more cautious in the policies that they bought, to hunt harder for bargains, and that in turn would induce the providers to be more careful in the money that they spend. We could provide incentives for Medicare beneficiaries to choose more carefully additional treatments by increasing the cost-sharing rates. Of course, those policies have consequences as well. More generally, the Medicare program reimburses providers in certain ways, and CBO reviewed a number of options in this volume of ways to encourage providers to economize on spending while maintaining quality. And that includes the way we pay for post-acute care after hospitalization. It includes the way we reimburse doctors, very importantly, because they tend to be paid now on a fee-for-service basis, not on a more bundled basis. On comparative effectiveness, more information is absolutely crucial. There's a very large share of medical care delivered in this country where many analysts think there's very little evidence about what works and what doesn't. And the largest variation in spending across geographic regions is in the aspects of care where there is the least consensus among medical professionals about what is the appropriate treatment. So that providing that information can then provide understanding about what's useful and not, and can try to reduce these disparities. But I think it's absolutely crucial to really get the effectiveness of this sort of research to provide incentives for using it. And that comes up against your concern, which is, well, who's saying that you can't get a certain treatment? And I think the answer here is not to the things people propose don't rule out certain treatments. What it does is to change the incentives so that doing another treatment is not a financial winner. It's a more of a neutral proposition for providers who would then recommend services only if they really are necessary and not otherwise. But the incentives have to go with the information to get the maximum effect.
Yeah, if I could, I'd like to focus on the cost-sharing piece of your question. I addressed the technology piece in my earlier comment. Having patients understand the cost of alternatives can be part of the solution, but it has to be structured very carefully. One of the areas where we think it can be particularly helpful is in Medicare Advantage, where if we give incentives, rewards to patients who enroll in more efficient, high-performance private health plans, that could be a step in the right direction. Our chief concern about Medicare Advantage as currently structured is that we are rewarding Medicare beneficiaries for enrolling in private plans that simply mimic Medicare, except at a much higher cost. So we think with restructuring, Medicare Advantage could be a significant contributor. As far as cost sharing at the point of service is concerned, when care is actually being delivered, of course, that is could be very problematic for very low-income Medicare beneficiaries who don't have much income and could impede access to care. And there is a body of research showing that, in fact, if you have cost sharing for some types of services, you can end up with worse results and higher costs. An example of that is drugs for diabetics. You don't want to impede access by having them share in the cost. A third point there is that well-structured cost sharing with protections for low-income people that doesn't discourage really needed things like drugs can be okay. But for the really sick patients, they're going to exceed cost-sharing limits. And the real money in our healthcare system is in the care of people that are really complicated and have very high bills. So cost sharing isn't going to solve that problem. We need other tools to address the issue.
Ms. DeGette.
Thank you, Mr. Chairman. I want to explore two sort of issues as we start to think about how we're going to fund health care reform. The first is an issue that I've been thinking about for quite a long time, which is that under the current system, the way the CBO funds health care is just simply by estimating how much it will cost to treat diseases and then paying for that. And a concept I've been working on, I'm calling it the prevention dividend. That's just what I'm calling it. The concept would be that we would try to figure out, and I've actually spent quite a bit of time talking to Peter Orszag about this. We would try to figure out if there are certain treatments or efforts that can prevent disease that we don't necessarily fund now because we can't afford it, and shift the way that we fund health care in this country. And I'll give you one example. When we did the Medicare Part D benefit in this committee a few years ago, I went to then Chairman Barton and I said, Joe, I think we should fund smoking cessation programs for senior citizens in this bill. And he said, I think it's a great idea, Diana, but we can't do it because I've got a $50 billion price tag and I can't go beyond that. So I thought, well, that's swell. We're not going to give them the patch, but we're going to give them treatment for their heart disease, lung cancer, and emphysema. Mr. Elmendorf, I'm wondering what you think of a concept like that, and how trying to structure a payment program for some kind of health care reform could take advantage of prevention.
So, Congresswoman, if you propose a policy to enhance prevention for a single or a range of possible diseases, then we would certainly try to take account of the effects of that policy on the subsequent prevalence of those diseases and the cost of treating them in the estimates. I think there are a few general points to make. One is that as researchers have looked at a range of possible preventive measures, some seem to be very cost effective and are not done enough. Others do not look particularly cost effective, much like the range of results people see for different sorts of health treatments, in which some things are not done enough and others are done probably too much. So I think it depends, the effect on the future disease and the cost of that disease depends importantly on the particular preventive service or strategy you have in mind. And the related second point is that when one engages in preventive services, there are certainly some number of people who won't suffer a very health damaging and costly problem later, but one is providing a lot of additional services to a very large number of people, many of whom would not have had that cost later. So part of the reason that preventive actions end up being less cost saving than one might think is because one is providing them to a lot of people at a small cost per person, to be sure, but to a large number of people.
But some of them do, I mean, in line with what the President said yesterday, I think all of this should be based on science rather than just our gut feeling. And so that would be part of what I would say, is you'd have to have some kind of longitudinal studies or some evidence that would show, in fact, that by giving a dividend to these prevention efforts, you would either A, improve people's health, or B, prevent longer-term disease. It's not just about preventing long-term diseases, it's also about improving quality of life.
Yes.
And Mr. Hackbarth, I see you nodding your head. I'm wondering if you can comment on this as well.
Yeah, I very much like the idea of it being science-based, because I agree with Mr. Elmendorf that you'll have cases where prevention can improve quality, but it may not reduce cost. And then you have cases where it will reduce cost a little bit, but not as much as the investment. So you need to have a very focused effort driven by science.
And you have to decide your criteria, because is your sole criterion saving money, or do you have the additional criteria of improving quality of life?
Right.
I completely agree. But would you think that would be an appropriate consideration? Prevention as we develop?
Oh, absolutely, guided by science as you've described it.
Right. Thank you very much.
Thank you. Mr. Burgess.
Thank you, Mr. Chairman. Glenn, always good to see you, and glad you're back here in front of our committee. Seems like old times. Let me just concentrate on a few things that you listed in your list of where we can see savings. And I was really encouraged by the physician group practice demonstration project at CMS, and I hope that has not died a natural death with the change in helm. But really, that seemed to be, you look at the 20% of the people that account for 80% of the costs, and that really seemed to be follow the old Willie Sutton's law, you rob the bank because that's where the money is, and that's where the money is in the Medicare system. I am concerned, and I think I heard both of you talk about increasing dollars to primary care physicians, a good thing, but anytime, since we're in a purely transactional environment, anytime we increase dollars to one, we're probably taking it from somewhere else. Is that a fair assumption, that this would be a redistribution across providers?
That has been MedPAC's recommendation, yes, that it be a budget-neutral change. And the reason that we've taken that approach is that As you know, total expenditures on physician services have been growing quite rapidly. As that's been happening, there's also been a shift in the distribution of dollars away from primary care services towards more subspecialty services and imaging and the like. So there's been a shift that we think needs to be addressed in the name of enhancing our primary care system. We don't think the problem is too few dollars in the pool, just how they're distributed.
And along that line, and of course, we always hear that removing the cost of administered drugs and imaging would be some way to provide perhaps some more equanimity in that situation. Is that possible to do that into the current the current structure?
Are you talking about under the SGR and
Yeah.
how the SGR is calculated? We've not really looked at the issues, not taken a position on the issues of whether drugs ought to be included. We think that those are more issues of budget baselines than they are of health policy.
Let me ask you a question on, because you talked about readmission, and that is one of the things that makes me enthusiastic about the process, but also frightens me at the same time, because of some of the things I've seen us do in the past that tend to be heavy-handed. Now, under the Physician Group Practice Demonstration Project, a patient is hospitalized for decompensation of congestive heart failure. If they're given, as they leave the hospital, the appointment time to see their primary care physician within 5 days, the risk of readmission really plummets. And if they are simply given the instructions to see their primary care doctor within 2 weeks, as opposed to actually having an appointment made, the readmission rate is significant, and those readmissions are terribly costly readmissions. So that seems to me to be a good thing. But if we simply say that we want you to take care of everything that might happen, or this is the way it may be interpreted by the hospitals and the physicians, we want you to take care of everything that might happen within the next 30 days because we're not going to pay you anymore. This hospitalization is going to be it. Are we perhaps going to tend to drive utilization in a way that we hadn't intended?
Well, we too, like the physician group practice model, that's what we refer to as accountable care organizations. And the ideal approach is to have aggregations of clinicians and providers with a broad target, and then give them freedom to allocate resources in the name of both improving quality and reducing cost, just as you described it. The challenge that we face in Medicare is that not everybody is prepared for that format. Not all physicians are part of our large group practices or even involved in a hospital IPA type format is used in Connecticut in the demo. Right. And so we need tools to apply in situations where the group practice model doesn't fit.
Correct, and that's why, of course, it was important to do it as a demonstration project. And I understand from the 10 institutions that participated, there was probably one that was not actually institutionalized as an IPA. It was more of a group without walls and organized through the hospital structure.
Yeah.
But at the same time, these were groups that were then allowed, gain sharing is perhaps not the right word, but if they met a certain threshold, they certainly were rewarded for meeting that threshold.
Yeah.
And that incentive to drive behavior. You don't want to pay doctors not to see patients because that's what we'll do. We'll not see patients. And then you get into the problem of his staff not being able to find a primary care doctor. That was the whole problem with the staff model HMO and a fully capitated environment. We don't work. We made all our money at the beginning of the month. Why struggle?
Yeah.
You close the doors and take the phone off the hook. That's the way to make money in that environment. And doctors are not stupid. We'll do that if that's what you pay us to do.
Yeah.
We have to be paid based on productivity as a general rule.
Yeah. So our goal, I think, aligns with yours, is to find ways to align physicians and hospitals and other providers to do the right thing, which is what they want to do, better quality at a lower cost. Our payment systems get in the way. So what we're trying to do is put some pressure on some places like readmissions, open some doors for people to go through with new opportunities like gain sharing and bundling of hospital with post-acute services, and say collaboratively, physicians, hospitals work together, reduce the cost, improve the quality, and share in the benefits with the Medicare program.
Well, I think the group practice model is on the right track, and I think sharing in that in the savings that occurs is on the right track. Bundling,
gentleman,
we'll save bundling for another day because I'm not sure I'm ready to go there yet. Doctors and hospitals, insurance companies do not trust each other at the present time. Thank you, Mr. Chairman.
The gentlewoman from the Virgin Islands, Ms. Christensen.
Thank you, Mr. Chairman. I'll begin with Director Elmendorf as well, and I'm going to try to follow up on Congresswoman DeGette's question. I was reading in Congress Daily today that there is a coalition of high-profile organizations on the Hill arguing that requiring offsets within a 10-year budget window does not look at the full picture, and it becomes a barrier to doing things that we're going to have to do if we're going to reform health care, as well as eliminate health care disparities. Because you don't see the benefits, you don't see the savings inside of that 10-year window necessarily. It takes a longer period of time. So what can we expect from CBO? Will this continue to be a barrier? Can we go outside of that 10-year window and budget for the savings that would be realized, both to fix the broken system that we have, to eliminate healthcare disparities, so that we won't be behind every industrialized nation and some developing ones for health status?
So, Congresswoman, CBO will continue to provide detailed estimates of the effects of health reform proposals over the 10-year window. We will try, where the evidence allows, to offer our qualitative judgment about the effects of certain reforms on spending beyond that. I understand your concern that there can be larger savings down the road that aren't captured. Unfortunately, we don't have the evidence or the modeling capacity to play out a whole set of specific reforms and how they are going to matter 10, 20, 30 years down the road. As I said in my remarks, many analysts agree on the general directions of policy, but there's much less consensus about whether the particular approach should be bundling, should be accountable care organizations, should be penalties for readmission rates, and a set of things like that. And that's the limits of the evidence as it currently exists.
Well, we look forward to continuing this conversation and seeing if we can find a way to address the costs that will have to be, and the money that will have to be invested to get to where we need to be. Mr. Hackbarth, we all know that Medicare plays a key role in our healthcare system, and there's several very strong aspects to the system, but there's still some areas that need work. We found that reimbursement rates within a city vary by zip code, for example. And we know that some of the proposed changes to Medicare, like those to Medicare Advantage and some of the ESRD reimbursement provisions, sometimes have a negative impact on subpopulations, largely African Americans and other communities of color. So as we make changes to programs, is MedCap taking this into consideration and looking for ways to reassure us or to ensure us that we are not inadvertently cutting access to needed services to some populations?
Yes, that's an area of increasing focus for us. For a number of years now, 3 or 4 years at least, we've been looking in particular at ESRD, the dialysis piece of the program, because that's so important to African Americans as well as others, and looking for any indication that changes in that system have impeded access for African Americans. In addition, we will be looking at the issue of access to kidney transplants, where there are some disparities in terms of access, and so this is going to be a focus of ours. We've also tried to look more broadly at differences in access to physicians and satisfaction with access to physicians.
Can I try to get
We've found some issues.
So you are looking at it. The bundling does bother me, and I believe as a physician and having been a medical director that information will change behavior. You're going to make the information public. Hospitals are not going to want to have a negative report given to the public. And I believe also that once hospitals are better reimbursed, which they would be when everyone is covered, they'll be able to provide the better services. So why a bundling pilot? It's going to put doctors and hospitals in competition, in ways that I just don't see why you think that would work.
Well, our goal is the opposite, not to put them in competition.
Or why it's needed.
But to put them in collaboration with one another. In the current system where they're paid separately, there is often competition, and as Dr. Burgess indicated, unfortunately, some places, some open conflict and hostility. We think that they need to be engaged, working together collaboratively to improve care, and we think bundling could be a step in that direction.
I agree, but I think that they need to work collaboratively. I just think there are other ways to do it. Thanks. Thank you.
Mr. Gingrey.
Mr. Chairman, thank you. Chairman Hackbarth, you had mentioned in your testimony, your written testimony on page 7 regarding payment system bias and the fact that many physicians who are subspecialists who do a lot of procedures are causing a problem in our manpower physician supply, particularly in regard to our primary care physicians. I know we have one sitting here in the audience from my state of Georgia, Dr. John Antalis, a former chairman of the president of the Medical Association of Georgia, who is a primary care physician. And I think about him. I think about my colleague, Donna Christensen, who is also a family doctor. Do you feel like this patient bias system may be a factor contributing to the various physician and nursing shortages we're seeing across the country? And what would you recommend that we do about that, possibly in regard to payment incentives?
Yeah. Well, first of all, I want to emphasize that physicians are responding to the system that we created, and the incentives that we create speak volumes about what kind of activities we value. And over a period of years, that means more subspecialization, more high-end imaging, and the like. So I'm not blaming them for what they're doing. They are responding to a system that we created. In the interest of a high-performance system, though, we need to redirect those signals that we're sending. And as I said earlier, we do think that payment deficiencies is one reason for the growing problems that we have in primary care. It's not the only reason by any stretch, but we think it is a very important reason, and so we need to get about changing that. And we've made a series of recommendations about how to change primary care payment.
Well, certainly, Chairman, that makes sense to me. And I, as a practicing physician for 26 years, as an OBGYN specialist, I concur that we need to do something about that to increase the number of primary care physicians and opportunities for medical homes, as we have talked about for all of our Medicare recipients. Director Elmendorf, let me shift to you for just a second. You talked about in your testimony in response to some of my colleagues' questions in regard to 10-year window, and that a lot of times you can't really measure or see the savings that are going to occur from various and sundry things that we have done. And it made me think about Medicare Advantage or Medicare Plus Choice and the fact that we are on the verge, if we follow the president, well, indeed, in the economic stimulus package and what he plans for health care to create that reserve account so we can do all of this reform of health care to take, I think it's $178 billion out of the hide of Medicare Advantage. Now, I don't know whether Medicare Advantage is working the way Congress originally intended for it to work. But certainly it was my understanding that the 10 million people that have signed up for Medicare Advantage are getting more than just episodic care. You know, they're not just going when their head hurts or their tummy hurts or whatever. They're getting a good annual physical. They're getting a call back from a nurse practitioner to make sure that they're taking their medication. And clearly, that's going to cost a little bit more. Now, I'm not sure it's worth 15% more, and I know that's a concern of Congress, but it's worth more in that you're investing in something. And you're investing, I would think, that in the long run, in the final analysis, that at the end of life, let's say, we don't spend buku-loads of money on those who have been under Medicare Advantage because they're healthier. They've taken care of themselves, and the doctors have taken care of them in a better way. We can't capture that, we can't score that dynamically, unfortunately. But I think at the end of their lives, when you look at it and compare the cost of fee-for-service versus something like Medicare Advantage, there may be a tremendous savings, and we're on the verge of gutting that. Would you like to respond to that in the few seconds that I've got left?
I think you're right that the patients in Medicare Advantage who are under the care of a managed care organization are receiving more integrated, more coordinated care than they might otherwise. Not all patients in Medicare Advantage are being seen by HMOs, though, for example. There have been patients under Medicare Advantage who are going through private fee-for-service plans, and Congress has taken action to reduce the number of people in that category. And that's the point that Mr. Hackbarth has made before about the importance of not just paying more for patients to receive essentially the same kind of care in Medicare Advantage. So some have been in that category. The others who are receiving this more integrated care, I think there are some advantages to that. I think most analysts, though, would be concerned about the point that you alluded to, which is that the reimbursement rates have risen relative to costs over time, and those patients are now receiving a variety of additional benefits that are of some value to them, but are costing taxpayers more per patient than would be the case in the traditional Medicare program.
Thank you, Mr. Chairman. Thank you for your patience in letting us go a little bit over. Thank you.
Thank you. Mr. Sarbanes.
Thank you, Mr. Chairman. Thank you all for being here. I wanted to pick up on this discussion of the primary care providers again, because to me, in many respects, that's sort of the elephant in the room. In other words, I've seen some statistics that say that if we were able to provide coverage for all those who don't currently have it, that in order to meet the demand that represents, we need another 60,000 primary care physicians. That's not even talking about nurses and other primary care professionals. So that's potentially a new train wreck that's coming. We talk a lot, and there's much of the debate and much of the focus is over the coverage side of this discussion. Is it going to be a hybrid, private, public? Is it going to be Medicare for all? Is it going to be single payer? Is it going to be employer-based, et cetera? But if we make the assumption for the moment that we will achieve universal coverage, then the question of who's going to provide that care becomes critical.
Yeah.
And there's a kind of a chicken and egg dimension to this. So if you could speak to that just a little bit more and maybe comment on the notion of having the design of the insurance be driven by the kind of providers that we're trying to bring, you know, if we build it, they will come kind of concept. Mm-hmm. Because I could make the argument that we should choose the insurance model based on
this is the second notice that the factory warranty on your vehicle may have expired and should be reactivated to protect you against the cost of repairs. If you have not responded to this
I'm going to talk through this,
not too late. Please don't make the mistake
we should
of
pick
driving
the
without a
insurance
warranty.
model
You are still eligible to
based
reactivate
on
warranty coverage. This is the
wanting to
final
get
call
more
before
primary
we
care
close the
providers
file.
in that. So
Press
what will
1 to speak
incentivize
with a
them
representative now
do that?
about your vehicle.
If you want to wait till
Press
that
2
stops,
to be
you
removed
can.
from the follow-up list.
I'm sorry, I don't know exactly what's going on.
There we go.
There we go.
Hold on. Does somebody have their phone on her?
Yeah,
I guess it's over.
I think it stopped, yeah.
All right, we'll continue.
Please.
On your first point, Mr. Sarbanes, that if we move towards universal coverage, we may increase the demands on an already weak primary care system. I think that may well be true. Dr. Gwande can maybe talk about Massachusetts, where anecdotally, at least I've heard that has become something of an issue. We think there are several responses appropriate within Medicare, and if you want, I can talk in detail about those. But in general, there are ways of increasing the payment for primary care, in changing the method of payment so that primary care practices can afford the infrastructure that allows them to provide appropriate coordination of care. Realistically, no matter what we do on the payment side, even if we did all of these things tomorrow, the increase in primary care physicians is going to occur slowly over a period of years. And that's going to be a real challenge for us. I think practically speaking, what we're going to have to do is expand our use of some non-physician clinicians, advanced practice nurses, for example, so that we can provide basic primary care to a broader population. I used to be the CEO of Harvard Vanguard Medical Associates in Boston, a very large group practice that made extensive use of advanced practice nurses to improve access to primary care. And I think as a national healthcare system, we're going to need to do more of that to deal with this issue as well.
One way to approach this healthcare reform is to figure out what elements of everybody's proposal are in common, and then bet that that's where the final design will be in terms of critical components. And I haven't heard any proposal with regard to coverage or providers or anything else that doesn't include the notion that we need more focus on primary care. So because it's going to take so long to get the pipeline going, we probably need to bet now that that need's going to be there, regardless of what we design, and get going on it.
Absolutely. There's a real urgency to move quickly on that front.
Okay, thank you.
Thank you. Gentleman from Illinois, Mr. Shimkus.
Thank you, Mr. Chairman. I want to congratulate my colleague, Mr. Sarbanes, too. I think that was a great line of questioning, something I hadn't considered, so I thought it was good. I think if we adequately compensate, and then I would say protect physicians. I come from a big litigious state. Medical liability issues really drive people out. My family practitioner who delivered my 3 boys no longer delivers babies because of medical. And we've talked about that, but in comprehensive reform, especially if the government takes a larger role in our community health clinics, there's liability protection there. I mean, the programs that are funded, and so that, I know some people aren't going to want to debate this, but it is a way to incentivize people to be in these professions, to give them some security. We still want people to get a redress for their grievances, especially if they're harmed, but that's got to be, I would think, and I didn't think about that till the line of questioning, so I do appreciate to that. I would also, in an opening statement, my colleague from California listed of things, well, why don't we do this, why don't we do that? I would ask the question, why do people from industrialized nations that have national health care, why do they come here for catastrophic care? Or I would ask another question, why are all the major medical advances around the world, whether it's in devices or pharmaceuticals, why is that done here for the most part? There is something that's still going right in this country that's helpful to health and lifestyle and longevity that we just want to be careful that we don't disregard. To that point, I think that the thing that I fear most is a one-payer system. And the OMB Director Orzog talked about no one is talking about using cost information to deny needed care to beneficiaries, and that patients need to be protected from being denied what they need. This comparative effectiveness debate that we've now entered into raises, maybe not intentionally, but raises that concern that we're going to use cost. And I'll let you answer. I'll just tell you the story that I used. I was at a local university talking to nurse anesthetists, and I can say that. And it was a pretty big group, and we're talking about a competitive model versus a one-payer system. And they were asking and I'm readily up front, I'm highly biased in opposition to a one-payer government-run system, and I am a market-driven individual. And so I wasn't trying to deceive them. So I said, here's an example, and I talked about some of the industrialized nations having formularies, and if you don't fit that formula, you get denied care. And then I get a hand raised in the back of the room. I use New Zealand as an example. And the lady stood up and she says, I'm from New Zealand. And I thought, I'm either right or I'm busted, man. I'm busted. And she told me that her father had to wait for kidney stone surgery for 8 months. Now, for those of you who had kidney stones, knows that was a terribly long wait. I guess my question would be, do you share these concerns as we move in this direction on a debate on national policy? Go ahead, Mr. Hackbarth.
So, Congressman, I think many analysts worry that our current system provides no reason for many providers and patients to think about whether extra treatments are cost-effective or not. It's also quite fair to worry, as you do, that we could devise a national health system in which cost would become the predominant criterion for what is provided and not. And that's why I think many analysts suggest moving in the direction of learning what works and providing incentives to take that knowledge seriously. But I think few analysts suggest that we should move to a system where one person in Washington decides who gets what. And one thing we will discover in future comparative effectiveness research, as has been discovered in past research of this sort, is that some procedures are very good for some patients and not very helpful for others.
Can I follow up? And I don't want to cut you off, but I'm going to ask this for the second panel. Defensive medicine in liability protection, will that be part of the cost-effectiveness analysis?
I think the consensus of researchers is that defensive medicine is a factor, but not a particularly large factor in the decisions of providers and patients.
But do you think we'll see that in this cost-effectiveness analysis? Will that be considered? I mean, we won't know until we get the stats, and if this is an issue of trying to figure out the cost, you would think that that would be part of the variables.
So I think the most direct connection is that currently, if one is facing a patient with a particular problem and there's very little evidence about what to do, then there can be a reason for the provider to do the most that can be done, and that can be expensive. Whereas if there were clear evidence on what worked and what didn't, that would help providers avoid having to prescribe everything to protect themselves. So in that sense, I think having the knowledge can reduce the amount of defensive medicine that is practiced, apart from the liability issues that you've raised as well.
Thank you.
Chairman's going to let me.
You want Mr. Hackbarth to answer the same question?
Yes, and I'll
Sure.
shut up.
Yeah, I was going to pick up where Mr. Elmendorf left off. Ideally, what we do is develop scientifically based, evidence-based standards of practice based on the best available evidence. It seems to me that if you have that information, then it can provide some comfort and protection to physicians that practice in accordance with that guideline, that standard of practice. When we're information starved, as we are so often now, the response is, well, do more. More is synonymous with better because we don't have sufficient evidence to show otherwise. So that's the refuge. We need to make create another refuge, if you will, so more isn't always the response to uncertainty.
Thank you. Ms. Schakowsky.
Thank you, Mr. Chairman. You know, we just heard an anecdotal story about somebody who had to wait for kidney stones, which my husband having had them, that certainly is a problem. But you know what? There's also millions of people, insured as well as uninsured, who wait a lifetime for the care that they need in this country, because we do ration health care, and by and large, that ration card is a dollar bill. And you can shake your head, but
If the general lady will deal, everyone who needs care gets it, because when they go into the emergency room, the hospital has to
The gentlewoman, I assume, has yielded to
I'm
the
going to
gentleman.
take back my, no, I'm going to take back my time, because the myth that everyone in this country receives the care they need has got to be dismissed, because that is not true. Over half of Americans, I said in my opening statement, the data shows, actually have gone without or postponed health care because they can't afford it. That is just a scientific fact. We have looked at the American people, and that's just true. But here are my questions. First of all, I wanted to ask Mr. Hackbarth, you talked about the percent of readmissions in hospital. What was that percentage?
About 18% of each Medicare admissions are followed by a readmission within 30 days.
Okay, I just wanted to have that. But I wanted to get back to this, this model. You know, we do have a single-payer health care system in Medicare right now for elderly people. And again, I had said before that this is a widely accepted and much liked, and it still has holes in it. And I wanted to ask about one of those holes. We've heard Medicare Part D lauded as something that has worked so well. But certainly in my office, we get people all the time confused over those many, many options. Senator Durbin and I and others in the House have introduced legislation that would create a public pharmaceutical option under Medicare. I wanted to get comments from both of you on whether or not, and that option would be able to negotiate with Medicare with the pharmaceutical companies for lower prices, hopefully to fill the donut hole. I wanted to get your opinion on that.
So referring to drugs specifically, CBO's judgment is that the private providers of the drug benefit do negotiate for low prices. They negotiate with the threat of moving drugs off of their formularies or charging higher prices for their use, and that there's no reason to expect that a public program would do better unless it were prepared to be tougher in not covering certain drugs. And if it were tougher in writing its formulary, then it could avoid, then it might negotiate for lower benefits. But that would be the crucial, lower drug cost, that would be the crucial factor. More generally in healthcare reform, when people talk about public plans competing with private plans, I think designing a system in which a public plan could compete on a level playing field is extremely difficult. It raises issues of what the providers are paid. It also raises the issue of selection of patients across plans and how sick they are. It's issues about how the financial risk is dealt with.
Wait, you're saying whether a public plan could compete with a private plan, who would be disadvantaged? Which would be disadvantaged?
I'm saying that if the objective is to have them compete on a level playing field, it's very
I know. Who would be
difficult.
disadvantaged? For whom would it not be level?
Well, under current payment rates, then a public plan would be less expensive because than the private plan, reasoning from the Medicare example, where the government does push down reimbursement rates. That would be a benefit for the public plan. The other issue is it depends just how you design the system. So there are risks associated with running health plans. If the public plan didn't have to insure itself against that risk, if it was just the taxpayers holding the bag, then that would be an advantage for a public plan relative to private plans that have to charge enough to cover that risk. That depends how it's designed. If public plans ended up with sicker patients than private plans because perhaps they managed benefits less tightly, that would be a disadvantage to public plans relative to private plans. So it's a set of parameters that you and your colleagues will pick that would affect whether one plan is whether a public plan is advanced.
Does it matter that the CEO of Cigna in 2007, for example, made $22.7 million, a cool $23 million, about more than the President of the United States in a year, and the kinds of overhead costs that private plans have as opposed to Medicare, for example? I mean,
yeah, so administrative costs are including the costs of paying executives are another factor that I forgot to mention. Medicare does have lower administrative costs.
For profits
and
for
even
shareholders.
large employer returns. That's right. But remember, the profits for shareholders, part of that covers the risks that I've just discussed. It covers the cost of the capital that goes into managing these plans. So some of that, that's why I said it depends importantly
well,
on
how is it, my time's running, how is it that the United States of America pays 40% more than the closest country for health care, causing the President of the United States to say, I think in response to something that Mr. Pallone said, are you saying that there's not enough money in the system currently to cover everyone? Are you saying there's not enough money in the system right now to cover everyone?
Oh, no, I didn't say anything like that. What I said in my testimony, and that is the position of CBO, is that covering everyone would be expensive, that there was also a lot of dollars spent in the healthcare system for which we're getting a little or no improvement in health, but that rooting out those dollars without also reducing some services that do improve health is challenging. And we've talked, and I think most people agree about the importance of information, the importance of incentives to use that information. But exactly how to do that, and how to do that in the short run, is not so clear. Again, the direction is clear, but how effective that can be, whether that can save enough money to cover the increase in health care that would be delivered to the currently uninsured, is much more difficult.
Okay.
No, that's all right. I'm just going to, take 30 seconds here as the chairman. What the president actually said in response to my question at the summit, and I think it hasn't been laid out here, is that you can have a lot of cost efficiencies, and that can contribute to expanding coverage. But he said that you do need a lot of money up front. In other words, those savings may occur as the reforms kick into place, but initially you're going to need a new source of revenue up front, because a lot of the things that we're talking about have large costs up front, and then the savings come later. So I mean, that's one aspect of this that we have to think about. But I want to thank the gentlewoman. Mr. Rogers.
Thank you, Mr. Chairman. Thank you both for being here today. You've said some things that I just make me scratch my head a little bit, and I think we're kind of dancing around some pretty important issues here, because we don't want to use the words that we know inflame the fears of most Americans, and that's rationing. And I have to tell you that as a Michigander, we can see directly the impact of a government-controlled system for health care in Canada. And as one Canadian told me, that if you break your leg in Canada, you have the best health care ever. If you get sick, it's the worst in the world. And I think what they're talking about is sustaining that system of health care is very difficult. And I find it interesting that there's a great number of our surgeons who do cash business with Canadians on weekends for hips and knees, because the system in Canada just rations care for elderly, and elderly starting in the 60s. And you said, Mr. Elmendorf, a couple of things that I found interesting. You talked about in this government-run plan that they would hunt for bargains and do those kind of things, and you said in order to work they would limit what coverage they had, and then later in answering questions you said in order for this to work there had to be some limitation for maximum effect on costs. And then I want to go back to something you said in your testimony. You were talking about the comparative effectiveness language would ultimately have to change the behavior of doctors and patients. And if they're basing that on information available
and a doctor's decision between a doctor and a patient, I'm for it. That's a great idea. But later you say bringing about those changes would probably require action by public and private insurers to incorporate the results in their coverage and payment policies. You are quite clearly advocating for rationing care through what is covered. And here's my concern. 85% of Americans have coverage. We often talk about the 15%. And it seems odd to me that we're going to say because we have this 15% that we should figure out a way to get access to health care, we're going to start rationing care for the other 85% who enjoy some pretty good health care in the United States. And maybe you can help me untwine that in both your oral comments and your written testimony.
So first, let me be clear. I'm not advocating for anything. The CBO does not make policy recommendations. So nothing in the testimony or in my answers to questions says that Congress should proceed certain ways on policies. What the testimony does say, and which I stand by, is that more information by itself is not going to have as large an effect on just providing information, will not have as large an effect on practice patterns and on costs as creating incentives for providers and patients to make use of that information. And I think that's consistent in what's written here and the answers I've given to questions.
Okay, but it says you require action to incorporate the results in coverage. And so when you say incentives, are you saying they should build that into the coverage, meaning they should restrict certain?
I'm not saying they should. I'm saying is that the rising costs of health care, which are linked to the increasing utilization of expensive services, that rate of increase is would be changed more if private insurers or public insurance plans created incentives for providers to take account of information about what was and was not most effective. And some of that information they will take account of anyway, but not as much as if there are financial incentives.
Okay, and just, I still think we're talking around it, but say that you're not advocating, even though I would say probably require, certainly sends a pretty clear message where you're going there. But in the other countries, and we've seen it in the UK, breast cancer, kidney cancer, Alzheimer's, and hip and knee replacements happen to be a big one. I think in the UK they just had one as young as 62 was denied care and coverage for a knee replacement. How do we avoid that? I mean, I think if we were going to be honest with Americans, we have to tell them, hey, this is what's coming. Because the only way we can fix the 15% problem is we're going to take it away from the 85% who have coverage. I just think we're smarter, better, more innovative than that, and I think there's a way to do that. But how do you stop that from happening, given your testimony today?
So let me just be clear one more time. The testimony says to reduce health spending, results of comparative effectiveness would have to be used in certain ways. Bringing about these changes would probably require. Again, it's not a statement of CBO's preferences. It's the chain of logic of what would be required to affect the path of health spending. I think the crucial point that many of us have made here today is that a large share of U.S. health spending does not seem to be improving health. You can look at and one particular piece of evidence for this is the geographic variation in spending under Medicare that does not appear to be correlated with the quality of care as judged by the measures that are available. That holds open the possibility, I think the very important possibility, that more evidence of what works and incentives to use it could squeeze out that money. It's a lot of money. By some estimates, $700 billion a year. As I noted before, doing that without affecting care that does improve health is not an easy task to accomplish, even if analysts generally agree on some of the plausible directions. So I think that holds open the possibility that we can reduce care that is not very useful and save a lot of money through doing that.
And then I understand. I think your words sometimes we're kind of parsing around what you're trying to say, and you're trying to say in order for it to work, you have to limit coverage in the future under government-run plans. I get it. Matter of fact, you also said that under a government plan, they would push down reimbursement. Well, if you've ever had a meeting with a medical provider in the last month and a half, and I'm sure you have, they can't get the reimbursement they need today. And it's having this inverse impact on private insurance companies trying to be asked to hold the burden of the government-run plan that pushes it down. So you're going to destroy competition in the market. I don't know how you think that works. And I don't know about my colleagues. We're getting calls in my office. People are in a panic because in cancer care reimbursement, where I think that you all have completely missed the boat, they're calling and saying they're not taking any new patients under Medicare because the reimbursement rates are wrong and they lose money. So to start out the premise that the government is going to push down reimbursement rates as a way to control costs and somehow a private plan is going to survive, it defies the logic of what's going to work in the marketplace. I don't know how do you reconcile that?
Again, I'm not advocating pushing down reimbursement rates. What I'm saying is that under the current Medicare system, Medicare pays less to providers than private payers pay. A number of options that we've considered, a number that MedPAC has recommended, in fact, but we don't make recommendations. A number of those options that have been discussed would reduce payment rates. In fact, under current law, as you know, physician payment rates under Medicare will drop very, very sharply this year. The evidence suggests that the shifting of costs to the private sector is not as acute as one might worry, that in fact the private insurance companies negotiate with the providers and achieve the rates of reimbursement that they can. To the extent that Medicare and even more so Medicaid pays less to doctors and to hospitals, that is taken out mostly in some combination of reduced quality or reduced amenities for those hospitals and doctors. Not clear how much of that, though, as I said, spills over to the private sector.
Yeah, I appreciate it. And just as a follow-up to Mr. Hackbarth, if we had had a government-run prescription plan under Part D, what would that have done to the competitive plans in Part D, in your estimation?
Well, MedPAC's never looked at that issue specifically. Of course, we have spent a lot of time looking at Medicare Advantage, which is a system where we have a public plan and private plans competing with one another. And there, far from the playing field being tilted in favor of the public plan, it's been tilted significantly in favor of the private plans. So in the one real-world experience we have with this idea, the fears that, well, the public plan gets favorable treatment has, in fact, not been the case. Having said that, I am a strong believer that we need both strong public plans and private plans in our healthcare system. I've worked in both. I worked in what was then HCFA, obviously deeply involved in Medicare issues now. In my prior lives, I've worked at premier HMOs, so I understand a bit about both. I think they bring distinctive strengths, different strengths, complementary strengths. On the one hand, Medicare as a public plan, as noted earlier, has low administrative costs, in part because of scale, in part because it doesn't incur marketing expense and in profit, as discussed earlier. In addition to that, because of its size, it's able to command low prices. On the other hand, private plans have some advantages as well. They are more flexible than a government plan can ever be. It's easier for a private plan to change how it pays providers to better reward the sort of behavior that we've been talking about today. It's a cumbersome process for Medicare to make those changes. It involves legislation and regulation writing and CMS and the like. So private plans have more flexibility there. In addition, private plans have the opportunity to try to identify a select group of particularly efficient, high-quality providers and direct patients to them, which is not feasible in a public program like Medicare. So you have two types of health plans potentially competing with one another, offering different things to Medicare beneficiaries. Some will like the public plan for what it offers, the free choice of provider and the like. Others might like Kaiser Permanente as an alternative. Rather than saying, well, we want one or the other, I think we ought to be striving to build a system that has both strong public plans and private plans competing on a level playing field.
Thank you. Ms. Baldwin?
Thank you, Mr. Chairman. One quick comment before I get to my questions. I know we've had a little bit of discussion about public plans versus private plans in the playing field, and even in the Medicare Part D context. I would draw attention to the fact that I think Wisconsin is the only state that does have a public plan in the Medicare Part D program called Senior Care. It was based on a pharmacy waiver that was granted prior to enactment of the Medicare Part D program. It is wildly popular to the degree that on a bipartisan basis, every member of the Wisconsin delegation weighed in to try to keep that program in existence as the Medicare Part D program was phased in. And I think it would provide an interesting analysis for some of the, to see whether some of the comments we've been hearing are really have a basis or not. To my questions, Chairman Hackbarth, I wanted to explore with you and have you talk a little bit about the value of demonstration projects as a way to go from current payment systems to perhaps testing some of the recommendations that MedPAC has made for reform. Congress, it seems, has funded through Medicare legislation for years demonstration projects such as the physician group practice demonstration or the premier hospital demonstration. Yet it seems like we fund those projects and don't insist that they're replicated elsewhere or expanded on a much more broad scale. I'm curious about their value to inspire confidence that new models of payment will achieve desired results, and whether we ought to be looking at more. Please comment.
I worry about this a lot and more over time, and I think it's an issue that MedPAC is going to try to think through more systematically, but let me offer some personal thoughts. We've got to make a lot of payment changes for all the reasons that have been discussed today. The changes that we need to make are sometimes operationally complex and uncertain in terms of their effect on cost and quality. And so it stands to reason that we may want to do tests of them first. The fear that I have about the process that we've been using is that often the tests are small, and so our ability to detect meaningful results is compromised. There are small projects that run for a few years, and we're trying sometimes to affect things that will only materialize over a longer period of time. And there's almost a bias in the design toward finding no effect. And then we throw out the idea and say, well, that didn't work, and we'll go on to something else, when in fact it may be in part a function of the limits of the design. A second issue is that even when things work, and I think you were pointing in this direction, then they've got to come back through the legislative process for further consideration and maybe modification in ways that might undermine whatever success we found in the demonstration. And so it seems to me that Congress may want to consider ways that we can accelerate that process, do more of what we've referred to as pilots, large-scale tests that will be better able to find whether it works or not. And if it works, according to pre-established standards, move immediately towards implementation as opposed to saying, well, let's now go back through the legislative process again. So those are a couple ideas, but I think we need to look at the whole process of innovation and payment and figure out where we can take out unnecessary steps and unnecessary resources and streamline that process. We've got to get better way faster than we are right now.
You and I have had a chance to talk about this sort of pilot idea before. You would conceive of that under the auspices of CMS, and are there good examples of that working in the past, or is this something that we would need to authorize?
Well, the most recent example was in the disease management pilot. It was retitled, I think, Medicare Health Support or something like that. And the intervention that was being tested was having third-party disease management entities counsel patients, provide information, make sure they take their meds and whatnot. In that case, the intervention was pretty large scale. The test was pretty large scale, and the finding was no effect. But the legislation had authorized the department to go ahead and implement program-wide if it had worked. And they found that it didn't, so we didn't go down that path. We need to do more of that. I think that's a model worth maybe tweaking some, but exploring for future projects. And bundling is an example that we have suggested a pilot approach.
Thank you.
The gentlewoman from California, Ms. Capps.
Thank you, Mr. Chairman, and thank you both. I read your statements. I wasn't able to be here, but I have a question for each of you, and I know I have 5 minutes, so we can base it accordingly. Both of you discussed the fact that we lack primary care coordination of and incentives for primary and preventive care. Mr. Elmendorf, you mentioned in your testimony that the potential effects of initiatives where we might invest more now, which preventive care is all about, and not realize the savings until later. This would be certainly true in efforts to offer preventive care services, but right now the CBO doesn't even allow us to account for savings. And as I've often said about a field that I care a great deal about, which is preventive health care as a public health nurse, there's no special interest group pushing for preventive health care. And so my question is, how do we integrate into our proposals a way to realize that the savings later are what we're investing now for? And if you could give me your response to that. I have a different question for you, Mr. Heckbutler.
So, Congresswoman, CBO does not just as a blanket matter ignore the health effects of changes in policy. The tobacco example was raised earlier as a case where we very specifically look at the effects of higher tobacco taxes or tougher tobacco regulation and try to trace that through to the effects on spending, for example, in Medicaid, the number of premature infants that are born and the costs of that. We are very actively looking for evidence to help us trace through the effects of changes in policies on health and then on federal and on private health spending later. So in no sense are we putting those issues to the side. We are focused on them. The problems that I mentioned are lack of evidence in many cases,
right,
or very long-run effects in many cases, and it's just more difficult to trace things out over several decades.
When you talk about tobacco smoking, it's a specific act, and when you talk about prematurity, there's a specific entity surrounding. I guess what I'm talking about in the area of prevention, some harder measures that are maybe more pervasive. Comprehensive health education for kids in a school curriculum, some subject dear to my heart. Most school curricula have no place for it today. And if we were to target things like that, maybe not that specifically, where it's general education, but targeted toward preventive health care, are you looking to us or to some academic, or some study group to measure the impact of the input and then some kind of impact and outcome?
Yes, so we look to outside researchers to guide us in the choices that we make in our estimating process. So on the tobacco front, there's been a wide range of research about the effects of tobacco.
How about obesity
on health
and
outcomes.
diet and exercise?
And I think that as well. I think on obesity, there are several steps of the prevention that have to work. So I think there is a good deal of evidence about the effects of obesity on health problems, less on how particular public policy changes will
So
affect
that's what we
obesity.
need to work on.
And that's when we look for
And
all
I
the
hope there are
evidence
some
in the world.
outside researchers listening who will help us take the ball. I want to turn to another topic, but that's one that certainly needs to be explored further, and I appreciate what you've just said. Mr. Hackbarth, in your testimony, you alluded to the declining number of medical students pursuing a career in primary care. This is been well demonstrated. Could you please expand on how you drew the correlation between Medicare reimbursement structure and this decline? And if I could just roll all my questions together, you'll understand. Could you offer some suggestions on how we would need to restructure a payment system to incentivize primary care, and how this would then spill over to private payers, if that's not too much for one?
So in the first question, the relationship between payment levels and the decline in interest in primary care, I'm not going to be able to point to particular studies off the top of my head, but we could...
Maybe you could get back to us if you know of some.
But certainly in talking to people involved in medical education, including some of our commissioners and other people that I work with in other walks, what I hear from them over and over again is that medical students, considering their career options, often point to a couple things about primary care that make it unattractive. One is the income level relative to other specialties. Second is the demands, the lifestyle demands that they experience in primary care, as opposed to some of the other specialties.
Could I interrupt by just asking, do you think the cost of medical school has anything to do with that?
It
I'm
could.
seeing a lot of people nod behind
Yeah,
you.
it certainly could. Obviously, if you're making a salary or an income that's 2 or 3 times larger, you can pay off those medical school loans a lot faster. And so the cost of medical education is not equal for all specialties, but it tends to be a real problem for people considering primary care. As far as what to change, we've made 3 types of recommendations. One, you're familiar with the process of establishing the fee levels, the relative value scale, and we've identified what we think are some problems with how that process works. In particular, we think the process focuses more on things that are undervalued and increasing values than things that are overvalued that need to be reduced. The net effect of that bias that we've seen in the system is to hurt primary care fees. And some steps are being taken to reform that process that we're cautiously optimistic about. The second thing that we've recommended is what we refer to as a primary care modifier. It's basically a bonus for physicians and other clinicians who, through their practice, demonstrate that they're committed to primary care. So it would be a modifier. You would get your fee plus an increase of 5 or 10% if you are designated as a primary care clinician. The third thing that we've recommended is a large-scale pilot of the medical home idea, a key element of which is to say for primary care, because of the unique nature of the specialty, we ought to pay not just fee for service, but on top of that pay a lump sum per patient to cover activities that are not included in the Medicare fee schedule, various counseling activities, following up on specialty referrals and the like, plus give primary care practices money to build some infrastructure, including hiring staff that would allow them to more effectively coordinate care, especially for complex patients.
Is that proposal? I'm so sorry. Oh, I know. I'd like to follow up on that topic with you, too.
Be happy to talk more about it.
Thank you. The gentlewoman from Ohio, Ms. Sutton.
Thank you, Mr. Chairman. Mr. Hackbarth, I understand you may have touched on this already, but I'd just like to expand it a little bit. In your testimony, you mentioned that one way to cut costs for Medicare is to reduce payments for hospitals with relatively high readmission rates for select conditions. You go on to say that we know that some readmissions are avoidable and, in fact, are a sign of poor care or missed opportunity to better coordinate care. The premise being, of course, that keeping readmission rates down is critical not only for saving costs, but for quality care. I'm interested, though, in what criteria would be used to deem a readmission as unnecessary or avoidable. I mean, how do we know that we're only penalizing hospitals for readmissions that could have been avoided?
Yeah. Let me just begin with a little bit of factual background. Okay. If you look at the rate of readmissions within 30 days varies according to the type of admission it is. So the rate is higher for some things than others. Take a condition condition like congestive heart failure or chronic obstructive pulmonary disease, very common reasons for admission among the Medicare population, you see as much as a four-fold difference between in the readmission rates between the hospitals that are the best and those that are lagging. So we're not talking about small differences here. There are quite large differences. Our approach would be to look at the readmission rate and set a threshold. And obviously, it's policy judgment about how high to set that threshold. But you could set it at quite a high level so that you're basically hitting institutions that are way above the mean, way above the average in terms of their performance on this dimension. And we believe that with appropriate incentives, and it could be structured different ways, that by focusing people's attention on it, we can improve performance. And there are models that they can look to. There are institutions, Don Berwick's organization, the Institute for Healthcare Improvement has really started to focus on teaching hospitals the things that they can do to reduce their readmission rates. So you want an incentive coupled with support, information on how to improve.
Again, and this is an example in a way of those preventative measures we can take to reduce costs. What we don't want to do is, though, have an incentive that goes too far the other way and people who need to be readmitted aren't readmitted. So that's the balance there. Mr. Elmendorf, I understand that in keeping with CBO's nonpartisan role, you can't offer recommendations on any specific policy options. But do you think if we fail to enact some meaningful health care legislation in this Congress, that the cost to tackle reform down the road will be greater? And if so, in what specific areas do you foresee the highest increase of costs?
Congresswoman, I appreciate your understanding the role of the CBO in this regard. Many analysts would agree that the changes in the health care delivery system that would be needed to improve the efficiency of delivering care will be changes that cannot be made overnight. As I said in my testimony, there are decades of experience following the rules as they've been laid down, the structure that the policies have been created, and a lot of ingrained habits, and devising the right sorts of incentives, collecting the right sorts of information, and then letting the healthcare professionals make the improvements in what they do is a task that will take time. So the sooner this process is started, the more unnecessary and ineffective care can be avoided. The longer that policymakers wait to create the incentives and help to provide the information, the more unnecessary and ineffective care will be given. And because the rising cost of health care imposes such a burden on the federal government and on the private sector, the more it will be necessary to make starker, more radical changes to balance budgets to let employers and families pay for health care down the road. And starting sooner is a way to make the changes most based on evidence and the most effective way.
Thank you.
Thank you. Mr. Murphy.
Thank you very much, Mr. Chairman. It's curious to me, listening to people talk on this panel and in other forums, about how we talk about this issue of rationing, as if rationing is some futuristic, catastrophic development that's going to happen in our healthcare system, when we know it happens every day, right now. Medicare makes decisions on who gets care and who doesn't. This Congress makes those decisions. And in particular, private insurers make those decisions, sometimes based on medicine, but other times based on cost. And so I wanted to bring one particular difference that I see between private plan management and public plan management to your attention and get your thoughts on it. When I was chair of the Health Committee in the Connecticut State Legislature, we brought in our insurers one afternoon to talk about a development that occurred in that the insurers had essentially stopped covering bariatric surgery across the board. Now, certainly there are a lot of abuses in bariatric surgery where it's more cosmetic than medical, but we know that there are plenty of circumstances in which it saves lives and reduces enormous costs later on in the system. The answer that we got from the insurers, not necessarily when they were all sitting together, but privately, was that because the average time that an individual spends on their particular plan is only 2 or 3 years before they switch to another plan, that it didn't make sense for them to pay for that enormously expensive surgery up front if they weren't going to bear the benefits of the person's extended health down the road. And it seems to me to be a particular handicap of a private insurance system and where people now, even if they stay with an employer or move from employer to employer, are moving from plan to plan over a long period of time. It's a perfect example of the tragedy of the commons. If they all made the decision to cover bariatric surgery, they would all be benefited, but they don't because they are calculating that they are going to pay the cost and not receive the benefits. And so in evaluating whether the question to you, Mr. Hackbarth, is how do you look at that particular problem as you weigh the benefits of public or private plans, and then to Mr. Elmendorf in terms of looking at how you score a new system that's reliant on the existing system of private plan management or an expanded public option. Is that an issue that gets considered in your cost estimates?
Mm-hmm. A couple thoughts. Earlier, I was talking about public plans and private plans each have distinct advantages. And if you're a private plan and you're in a market where there's lots of turnover in your enrollee population, it would be surprising if they didn't make the sort of calculation that you were talking about. I'm not going to have this patient in the long run, and that could influence their thinking. I don't think that's true of all private plans, however. There are some, like Kaiser Permanente, who take the long-term view, in part because they have pretty good stability in their membership, but in part also because it's the right thing to do. So I wouldn't want to cast all private plans in the light of being calculating green eye shade types that are just looking for short-term profit. Some are that way, others are not. The last comment I'd offer on this whole subject of rationing is that, it's been characterized, well, the haves and the have-nots. That's an important dimension of the debate. But let's just focus on the haves for a second. I think we're all of two minds about the soaring cost of health care. If we are the patient or our loved one is the patient, of course, it's only natural that, we want access to the latest, most innovative treatment that can help them get better. On the other hand, we're also all taxpayers and premium payers. Mr. Elmendorf can correct me if I'm wrong, but I think this most recent economic expansion was pretty unusual in that the median income did not rise. And a big part of that was health care was taking the money out of people's pockets. And there are a lot of Americans who are very worried about that, in addition to the possibility of losing their health insurance altogether. So, I don't think this is haves versus have-nots. We've got finite resources as a society. We need to figure out how to use them most effectively to achieve all the things we want to achieve.
To the extent that a public plan would provide more services now that would save costs down the road, that's something we would certainly try to incorporate in our estimates. As I've said a couple of times, it's very difficult to track all of those effects, but certainly something we would try to have in mind. The only thing I would just add is that incentives can be created for private plans that would not otherwise do the sorts of preventive services that are important to do them. The government could pay for vaccinations, flu shots, things of that sort, administered through private plans or through public plan. So there are ways to work through the private plans to accomplish some of those objectives as well.
Thank you. I think that concludes our questions, so I want to thank you very much. You know, first of all, you raised some major new ways of doing things and looking at things and all the cost efficiencies, and, you know, it's very helpful in terms of our trying to craft healthcare reform. So thank you very much. Thank you.
Thank you, Mr. Chairman.
And I'll ask the next panel to come forward.